the recording, thank you. But before I hand this over to Dr. Pascal, I'd like to just get maybe two people who will tell us what is their expectations for today. And if you're looking down, I will put the mic to you. You're not looking down, huh? What's your expectation for today? Introduce yourself.
Okay.
And where you're from, organization, country.
Okay, thank you very much. I'm Caleb Malaku. I'm from Kordid and I'm from Ethiopia. My expectation for today is to get a better understanding of the interventions that are being done in regards to strengthening community health system to address UCH in low resource settings, as the title suggests. So, yeah, basically.
All the way from Ethiopia. That's exciting, right? I'm going to look for a lady. And you're looking down, madam.
I don't really speak English very well. French. Bonjour à tous, c'est Nefat Senghor. Je fais partie du centre de santé, centre de recherche de Dakar, une assistante de recherche. Donc, j'attends de cette conférence que les organisations soient financées et que j'ai plus de connaissances que j'en avais avant. Merci.
Merci beaucoup. Merci beaucoup. Thank you so much for testing our translating. Are you guys speaking English? Understood very well?
No, we didn't.
Did you understand? Is there some translation? If not, then we need to address this so that we can find a way to translate so that everyone can understand a bit something. So if the translation, the technical team, technicians.
We can sort that out, but maybe you can translate what she's.
Okay. She's coming from Dakar. She's a researcher from the Dakar Research Center. Okay, Senegal. So perhaps while I was discussing more, I don't want to miss your word. So you can say, quelles sont tes expectations d'aujourd'hui? Qu'est-ce que tu penses que tu vas avoir aujourd'hui? Et puis, je vais faire la translation.
Bon, je l'ai dit tantôt, je veux avoir plus de connaissances et de compétences sur ce thème-là, plus que j'en avais.
She wants to get more of understanding and knowledge on the theme than she had, and she's looking forward to learn more on community intervention, community health financing intervention.
Okay, great. Thank you very much. In terms of translation, we all received an email from the AfHEA organizers. Please download the app. And if you need translation services, you can just plug in your headphones or headsets and you'll get translation direct from the AfHEA app. Okay, without further ado, over to you, Dr. Pascal. Please tell us what the session, what we expect today, and then you can present the first presenter. Thank you.
Okay, thank you very much, Wendy. Before I introduce our speaker today, let me first just give a very brief background of the community health programs, community health financing, and everything that is done by community health workers. We all know that community health workers are the backbone of the health system, and we can't reach universal coverage without community health workers. That is already proven. But today, it's so unfortunate that many of our country do have community health programs, but still, they're still very, very weak, and part of the problem is their financing. I know we do have all different problems, but their financing remains one of the crucial, and perhaps one can say everything is health financing, because if we have enough resources, we can outsource even, we can have more infrastructure, we can outsource human resource for health, we can do everything. So all around, everything is health financing. So with this one, we at FH is Financing Alliance for Health. It is an African-based organization, African-led organization, African partner-led with the government in Africa to find solution to our own problem. So today we seized this opportunity to know that you guys, you are here with us at this side event during the AfHEA conference. We know that we have so many brain around, and we want just not only to give, because we know you know everything, you know most of the initiative, financing initiative, but we want to sit together discussing what can be other initiative that we can bring. So we think out of the box. We know we have community-based health financing, we have community cooperative, we have community performance-based financing, we have so many financing mechanisms. But now we want to sit, discuss what are the challenges, what are the opportunities, what can we do better to make sure that the financing of community health program, including community health workers, are well done so that we can move forward universal coverage. Remember, we only remain with less than 5 years. And in Africa, less than 50%, even more, 40 something, those are the population that are accessing essential health services. So what can we do? With that, how we are going to do this day, today the agenda, if we can have the agenda. So we pass through the agenda and we start our day. So today agenda will start by the presentation of financing community health system in sub-Saharan Africa. And then from there we will have different mechanisms that we exist and others that are still in pipeline that we're thinking, and how we can now do it together. The second one will be a panel discussion. We'll have panelists who are well experienced, and are from the ministries, are from different stakeholders and different countries, so that they can just tell us from the presentation on technically what is on ground. And this is from different countries. And then after, we will have second presentation, which is assessing community health financing in Senegal. So we will have first the Senegal will tell us, then we will go on assessment. Are we really Senegal? What are we doing? It's not about what are we doing better or bad. It's not, that is not the objective of the day, but what are we doing and how, what can we do to do better? So the third one, then after we'll break for lunch, and then afternoon we'll have breakout session where we will now have to discuss very well, technically with different experience and knowledge from everyone, and is where we need you more. Then later, we will do a recap of the day by Dr. Parfait, and then the closing remarks and what next. So without overdue, let me introduce Denise Munguti. But Denise Munguti is the Director of Country Engagement in the Financing Alliance for Health, is a health economist. is first an economist and then health economist, because you can be a doctor and health economics, but for him, he's an economist and health economics with various experience in health financing, including domestic resource mobilization, efficiency, equity in resource and allocation. So, and before joining the FH, he's a consultant. So it means that he has a various on-ground experience across different African countries, mainly Anglophone country. So the floor is yours, Dennis. Thank you.
Thank you, Dr. Pascal, for the introduction. Hi, everyone. Hope you're doing well. And I hope you're all excited for today's conversation. I'm truly privileged to be amidst such great minds and also gifted hands. So as well, I do appreciate you really creating time out of your schedule to join us. Before I begin, I would like to dedicate this session to a special kind of healthcare workers. I know physicians, dentists, nurses do an amazing job, but there's a special kind of health workers that have access to households more than anyone else, has access and know our communities better more than anyone else within the broader healthcare system. Who do you think that cadre of healthcare workers is? They live amongst communities, they engage households on a regular basis, more than even facilities, more than dispensaries. Who are they? Yeah? Amazing, yes. Community health workers. Community health workers show up for us in many ways. Community health workers show up for us within our communities. They show up for us to our grandparents. They show up to us to our parents in both rural and urban settings. They are at the last mile, right? Delivering crucial life-saving and essential healthcare services. It can be preventive, it can be promotive, it can even sometimes curative. So they show up for us in a huge way. But how are we showing up for them? Because most often they remain to be unrecognized within government policies. They don't get their fair compensation in regards to be it performance pay, be it stipends, right? They still remain not to be institutionalized within the broader healthcare system in most countries. And also, they're yet to be professionalized. By professionalized, I mean trained, equipped, right? But once in a while, they do get recognized more so during immunization campaigns. But then after the campaigns, they're left, right? So they show up for us in many ways. How do we show up for them? In this room, I know they're budget approvers. In this room, I know they're technical experts. In this room, I know even they are presidential advisors, right? In this room, right, we have advocates who have access to budget approvers, to the legislative arm of the government, right? We can show up to them in many ways within our ecosystem and where we work and our duty stations, right? So today's session, I want to plant a seed and I want to set a scene for you, right? Beyond this session, even as the course of the week goes by, I want to plant a seed of intention around how we show up for community health workers, right? And I want to do it in a very simple way, okay? I hope we all have some notepads and a pen. I want us to do a very simple exercise before we kick it off, okay? So please, please everyone, get a fresh page on your notepad, a fresh page on your notepad. Fresh page on your notepad. I'm hoping I'm audible. I'm hoping that I'm able, the translation is happening. A fresh page on your notepad. Are you everyone there? So I want the title to be AfHEA Vision Page. So it's a visioning page beyond this session to all other engagements that you'll have beyond these today's sessions with the Financial Alliance for Help. So it's AfHEA Visioning Page. And I want you to draw, I'm not good at art, but I want you to draw a circle, a 360-degree circle. I want you to name it Sub-Saharan Africa, Fiscal Pie. And I want to unpack something. If you love publications, in the last decade or so, if you love publications on health financing, there's a statement that most authors use, or even articles, right? A good example is in the past decade, fiscal space in sub-Saharan African governments has been constrained with declining external funding. Have you ever heard of that statement? It's used in a lot of publications as the first, like the problem statement, actually, right? I want to unpack that for you today, okay? And I want us to unpack together. I know maybe in the room there are health financing specialists, there are health economists, but I want us to unpack it together, okay? So governments operate in a fiscal pie, right? Each and every year, government has to develop a budget, right? And in the budgets where priorities go to, this pie, and that's why I'm calling it a fiscal pie, determines who gets the share, right? Others get bigger shares, others get smaller shares, right? But there is a process to it, and a priority to it, and a political aspect to it. So I want us to unpack for Sub-Saharan Africa. I want us to see how Sub-Saharan Africa divides its fiscal pie, okay? For a start, we'll start with the domestic pie. Basically, the money that they have domestically, the money that they generate domestically, and how they distribute it to the various sectors. Okay, are you excited for that? Okay. So have you all done a circle? So I want you to draw, let's say, half of it, or around 46% of it. I want you to do this. That's basically around, not really 50%, but around 46%. So at the start of each financial year, each budgeting process, majority of sub-Saharan African countries split more than half or less than half of their budget into three sectors or into three priorities. So divide it into three. But then not equal, there's one that gets a bigger share, and I will be able to tell you this. So who can just guess who gets the first biggest share of the pie? Yes? Who gets? Yes, sir?
I think it varies from one country to another, but most of sub-Saharan Africa, well, they invest in security.
Yes.
Yeah, they invest in security. For the case of Rwanda, health is one of the biggest priorities. So I think it varies from one country to another, but
Yeah.
that's around.
So my brothers mentioned that it varies, but I want to surprise you today, right? Sub-Saharan Africa is a very interesting kind of region compared to other regions. I'll say, for instance, comparing to North America, there's huge disparities on how they spend their money. Like, for instance, if you go to the USA, they spend a huge chunk of their health investments or their GDP to health compared to Canada. US is majorly driven by private sector. Canada is public. If you go to Europe, where the Western region, Western kind of part of Europe, they spend more on like healthcare than the Eastern. If you go to Asia, South Asia spends less, both in infrastructure and healthcare compared to China, Japan, and Korea. But Sub-Saharan Africa has similar traits in how they spend their money. There are 53 countries, but they have similar traits on how they spend their money. So you've mentioned health, defense, right? Anyone else who wants to give it a try? Let me give it another hint. So 17% of majority of Sub-Saharan Africa countries budget 17%. Who do you think takes this 17%? I've given out another hint. Education, amazing. Almost there. Security. So to your surprise, the 17% of this share of domestic revenues and budgeting from Sub-Saharan Africa goes to debt servicing. Okay, so just put there, debt servicing. I also want you to put an asterisk and say China. Just put China. Okay. So who can guess who gets the next share? And I'll put it at 15%. Someone got it right here. And I like, engage, so don't worry when I'm moving around. Who gets the 15%? Education, amazing. So education gets the next share of the pie, of our fiscal pie. The next one is 14%. Another guess? Then I'll make it easier. Now it will become easier because now we are going through the sectors. 14%, agriculture, almost, yeah, almost. I want you to visualize in the context of your workstations or your home countries. Because the president needs to move around. Huh? So 14% goes to public administration and governance. Public administration and governance. So this is what covers the judiciary, this is what covers legislature, this is what covers the vehicles that the system drive around, right? So it's public administration and governance. So already half of our fiscal pie, half of our piece of cake, half has already gone, right? But then don't forget we're here because of health, right? We still need to advocate for health. Do you believe the next share of the pie is health? Nope. Who do you think gets the next share? Just a bit smaller than the rest. It's actually agriculture. Don't forget, agriculture is a cradle of a lot of these sub-Saharan countries. So agriculture gets, on average, really depending on the country, but around 5 to 8% of the budget pie. So I'll give it at around 8%. Do you feel we are close to health? Do you still have a long way to go? So two more. There's a 7%. They usually tie. Who are they? Health. And health and who? Health and sick. No, be quite surprised. A lot of sub-Saharan African countries don't do, depending on really the geopolitics and your neighboring countries, a lot don't really spend on military and defense. But so this one is split between health and who? Perfect, and infrastructure. So even as you go and within your duty stations, even at the start of the planning and budgeting process of governments, already we are losing a battle for investments in health, right? And there are still other sectors, right? So it's usually a competing kind of priorities, a compete of priorities against who gets what, right? I want to finish up. Let's finish up this pie. And I'm hoping everyone, whoever is new, so we are doing a simple mapping exercise of who gets what within majority of sub-Saharan African governments, right? We are trying to map out. It's called a fiscal space analysis, right? And we are unpacking a very simple statement, a well-known statement that says that in the past decade or so, in the past 20 years or so, fiscal space for governments, sub-Saharan Africa governments has been constrained with donor funding dwindling. It depends, as I say, declining, dwindling. So that's what we are trying to unpack. So the other sectors also get their fair share of the pie. So a good instance, the next one is usually trade and commerce. For sure, defense has to get its fair. And the rest, you can say it's others, which is, let's say, miscellaneous. And there's also even environment as well. Environment has been getting a good share. Miscellaneous can be social protection programs or anything else that is not really within these broad categorized sectors. Okay, so I also want to do another interesting. So you've seen that half of the budget goes to 3 sectors. And you've also noted that debt is emerging, right? Majority of sub-Saharan countries have a range of debt to GDP ratio of between 40 to 70%. That's quite alarming, right? We've also noted that education is also getting a good fair share of the pie, and also public administration, right? So, but we can't be that naive. We know that health systems or even other sectors are not only funded by domestic revenues, our taxes, right? Or our premiums we contribute to social health, but there are also other partners, the other stakeholders, right? That put in money within the sector, right? So this one is only domestic. So this one is a domestic pie. So who else do you think injects money within the pie or within the sector, within the fiscal space? Who puts more? Who puts? I want us to list the other partners, the other actors who put in money beyond the government. Okay? Are you on the same page? So this one is government. Okay? Taxes, revenues, a bit of out-of-pocket expenditures, but we don't operate the government alone. Other actors do come and inject more money. So just shout who you know. Can be a funder, it can be a donor, but now let's be precise. Let's stick to the health sector, because if you get all other sectors, it would be a huge list. So let's get the people we know within the health ecosystem. USID, perfect. So now mapping out who brings in money to the health sector. So there is USG, right? The US government, so puts in money. Who else? Global Fund, amazing, thank you. GF puts money. Who else? UK puts in money. Who else? Private sector, BMGF, right? BMGF. Who else? Buffett. So let's put them as let's say philanthropies, right? Or even the private sector. Who else? Who funds you for assistance? Basically, who funds you? Amazing. Out of pocket, right? It can be, oh, okay, yeah, but let's say out of pocket, but also, let's say, social health insurance. And also for the private health insurance, it can be at the private sector. Okay? So this is how health systems are funded. This is how, from the domestic aspect, this is how they get their fair share of the sectors. And also these who are the ones, these actors are the ones who come in, right, to complement the funding that gets from the other sectors, be it private sector, be it bilaterals, be it multilaterals. Even, you haven't mentioned IMF, right? IMF, World Bank also fund, right? So let me include IMF and the World Bank. So if once they say that health sector investments are either been on the rise, when they say that the fiscal space is constrained, this is what they mean, right? So I've given you a projection of the last decade, how the trend of investments that have been going into the whole sectors, but also specifically the health sector, okay? Now I want us to forecast. In the next 5 years, given the geopolitics that are happening, given the USD freeze, given how you know your economy is very well, I want us to see how money will be flowing, all right? Will we change the narrative to declining external aid, constrained fiscal space? Will that change, right? Will it come to more domestic investments? I want us to map it out, okay? So let's begin with USD. So do you foresee investments will increase or decline in the next coming few years? Let's say 4 years. Let's have a time frame of the new administration period. So USD, will there be an increase in investments or a decline? Decline. So where there is USD, put a declining arrow. Okay. I'm hoping you are still mapping out. Who else? Global Fund. Why? Yeah. Yes. So USD contributes the last cycle, the replenishment cycle. It contributes almost 25 to 30% of the total replenishment. So there might be some implication to GC8, the next coming cycle. So that's a decline. UK. Yeah, you had Prime Minister Starmer say, "Hey, our little money, let's put it into more of military kind of support." So BMGF, yeah, philanthropies are stepping up a bit to fill up this void. So that's a decline, an incline. World Bank. World Bank. Yeah, so to be noted that World Bank, Africa Development Bank, IMF, the biggest stakeholder is USD. So they might also be implicated, and also there might be also a potential reduction. So both IMF and World Bank down. Out of pocket expenditure, it will increase, right? There's a high correlation between investments in the public sector and out of pocket. So if the public investments are high, right, out of pocket expenditure usually declines. So there'll be an increase. China, increase. Can I shock you? Who else? China is increased. Is there a consensus that China will increase the investments? Sorry? In general, because either way, some money can trickle down to the health sector. Even though there are commercial loans, but you never know. Or rather, at times, at least this loan can come into various sectors, like in the infrastructure sector, then it leaves a bit some wiggle room for negotiations for health. So there's usually even a benefit. But then while you assess China, you need to know there's a background story to it. China in the last 20 years, the economy was doing very well. We call it the golden years of China, right? Industrialization, right? And even in the global market, they are doing very well. So as governments, if your economy is doing very well and it's generating a lot of revenue, you don't inject it back in the sector within the domestic fiscal space. There'll be inflation. So you inject it outside as foreign direct investment. So for China, they chose commercial loans. Quite pricey. In the last couple of years, every 1.5 out of 3 projects in Sub-Saharan Africa were done by China or were financed by China. Okay, China is the biggest single lender of loans in Sub-Saharan Africa, right? And we know their loans and how they're tied to even our country assets. So China in the last 20 years were doing very well, and we are dishing money, Yeah, their money was flowing, right? So they gave out a lot of loans. But now in the next coming few years, China's growth is kind of stagnated, right? Their raw materials, majority of them have been exhausted. It's becoming more expensive to produce in China. Their goods are becoming more expensive, right? There's a social economic shift as well. The governments need to put more money into social protection. So China will be wanting their money back to inject into the economy. So there'll be a reduction really, unless there's a very strong investment case for China to put money out to give you a loan. There'll be it has to be a very strong investment case with a very high return. So loans will also, for governments, will also be expensive. So that's something you need to keep in mind. And now governments will also need to be paying, because if you don't pay, if you guaranteed your loan with a port, they'll take charge of it, right? And these are conversations that are also happening actually in Kenya as we speak. So China loans will be declining, but then the governments need to be repaying their government. So the pie, as you can see, is declining. I just want us to reflect on that. So majority of our money or external aid, for sure, we've proved together the narrative that is right? That fiscal space is constrained, donor funding, external aid is declining. Have you proved it with this mapping? But are there any opportunities for the narrative to change? Do you see any opportunities that we can leverage on? So private sector, yes, contribute a significant amount of money within the systems. I don't know, can you please present the screen slide so that I can show you the true picture? So private sector is a significant contributor, but we haven't really leveraged it, right? Private sector, even if it's the health sector, they have very amazing, well-structured supply chains, right? Even infrastructure. So it still remains to be underutilized. Another aspect is debt, right? So can there be conversation for debt swaps, right? Can there be conversations for health to debt swaps? There's a conversation that's actually going live in Kenya right now for environment. So there's a loan from the German government. So the Kenya government has managed to negotiate for a debt swap in exchange of building more of a green kind of energy plant. So there is a possibility of debt swaps. What else? Yes. Mm. Yeah. Yeah, but still, the debts have already been taken, right? Governments now have to pay. The next 20 years, they have to pay. So there's room for negotiations, right? It's usually a difficult process, but there is a room, right? We're looking at opportunities. The little shade of light right? That can work. Another aspect is you've seen education, agriculture, there's environment. For health, do you feel like there's an opportunity for multi-sectoral partnerships, right? Leveraging on agriculture, right? Education, right? They're all interlinked. They're getting significant amount of funding. Again, opportunity for multi-sectoral partnerships and financing arrangements. Which other opportunity? Yes? Yes, that's where I'm coming in. I'll put it here, social, health, insurance. And this is what most governments are not really leveraging on. By the end of the day, the biggest and the largest purchaser of healthcare services is the government. By the end of the day, the government who spends the majority of the money paying for services, for provision of services to the populations, right? So if they are not well structured through pool mechanisms such as social health insurance schemes, then there'll be a lot of leakages, right? And inefficiencies in how they purchase for the healthcare services. So social health insurance will be very key with these limited resources that are coming and also out-of-pocket expenditures. Of interest is that when you see a country having high out-of-pocket expenditure, it shows that in absolute terms, households do really have the money, right? That's why they're going to the pharmacies, right? That's why they're going to the private sector. They do have the cash, but why aren't they channel it into social health insurance schemes? That's usually the biggest question. Why isn't there the demand for them to? Is it a supply issue? Is it that we governments or the governments, we haven't really sensitized the households on social health insurance schemes? So there's a huge, huge opportunity. Next slide, please. Sorry. So this is the context in terms of money, right? And a couple of years ago, our government stakeholders, we ourselves partners, we sat down and we set about ourselves with targets, right? Declarations. The most famous one, for instance, the Alma Ata, the Abuja Declaration, the UHC, right? SDG, right? So as part of AfHEA, we usually map out all these declarations and we compare it with indicators across all countries in sub-Saharan Africa. So the infograph you're seeing above is a comparison of all global health indicators coming from health expenditure, coming to social health protection indicators, to maternal and child health, to sexual and reproductive health, to HIV/AIDS, right? And the goal is, based on these declarations that we set, is to move from red to green. What do I mean? If I say maternal, let's reduce, for instance, let's increase the number of mothers accessing antenatal care to at least 4, right? For at least 4 visits, right? So we need to shift those percentage of mothers that are accessing from the target we were to what for instance, SDG 3.1 has said. For instance, for SDG, we need to be ensuring at least 90% of mothers are accessing at least 4 ANC visits, right? So we need to move from red to green, right? But amber is also good, right? Amber means progress, right? And green shows that we've achieved. So we've compiled all data, so various both in-country data sets and even external ones across all countries. But now we've just kind of showed a representation of Kenya, Zambia, Senegal, even Somalia, South Africa, Malawi, just a good mix of representation of sub-Saharan Africa countries. With less than 4 years to SDG 2030, right? Majority of the countries are still at red. I want that to sit in. And we've had other declarations move from 20 years back, right? We are still at red. But there's good, like countries like Rwanda, there's a good representation of amber and green. Issues such as HIV across countries also progressing very well. You can see a bit of amber on the, I think almost the last slide, the last rows. HIV is also doing very well, but then there's been significant investments for HIV, from also for external. So you see, there's actually improvements, but across all, SRH is all red. Can we shift this in the next coming 4 years? Who's hopeful? Yeah, okay, okay. I'm a bit skeptical, but do you feel like we can accelerate this to by 2030 they are green across all these indicators? And if I expound more to be 53 countries, it's worse. Because I put example a country such as Rwanda, South Africa, they're doing very well. A bit of Kenya, no. But at least if I expound it to all 53 countries, right, you won't be able to even see the green. So let that sit in as well. Let's reflect on that. So we have limited resources. I've already shown a very interesting exercise for you. This is what health economists do, right? And this is where the narrative comes from. So investments are dwindling, right? Outcomes, acceleration, advancements, right? They're not doing very well. And in 2030, we'll still be invited again as stakeholders, as government, and we'll set up new targets. But what aren't we doing right? Right? And that's the seed I want to plant into you, right? And it's beyond this conversation we're having today. I want you to really plant the seed, even with the other engagements that you'll be having over the course of the week, inside and outside. Even as you go back to your home countries and your duty stations, this is a reality of majority, right? Maternal deaths are still on the rise, right? So mothers are actually dying, children are actually dying, right? People are actually going into poverty because of high out-of-pocket expenditures. The second reality, so this is the first reality, yes? Yeah.
Sorry, please use the mic so that everyone can hear you.
Yes, Somalia?
Yeah. Yes, thank you.
Yeah.
For Somalia, all indicator is red.
Yes.
But when you go to catastrophic health expenditure, they are good. I don't. What is secret? The secret.
Because actually, the people are not actually even in pay, right? They actually even know facilities for people actually to go to. And also another thing you'll see in Somalia, there's a lot of data gaps, right? Again, access to data, right? People are actually not even gathering that data, right? Very well. So there's also a lot of gaps. Even the data tells the story around the context for these countries. So you can take a picture of this, let it also be part of your visioning board. I also have a clear picture for the mapping exercise that we've just done. Again, now these are the actual. So as you can show, there are some like kind of bounds, right? Either 2 to 7%. But even if you search for specific countries, this is how the physical mapping looks like. And this is how even the plus or minuses of the percentages of allocations look like. Health sector is 5 to 7%. It has always been around 5 to 7%. Another very worrying indicator is that half of all sub-Saharan African countries pay more in debt payments for their loans than actual healthcare expenditures. Again, another reality for you to sit in. As part of the assessment that we've just done, I wanted to show you something interesting. So I wanted us to map out, but we can start from the first one. So the graph shows investments in the health sector over the last 10 years. I took 10 years. But it's good to note that health investments has been in an increment, an annual increase of 3% from all funding. But to be very interesting is to see the bluish one is the government. So government expenditure has actually been on the rise, but then unfortunately, so it's out of pocket expenditures has also been on the rise. So in the last 10 years, we spent around 19% of all the investments have been coming from out of pocket. But then donor funding, and that's why we did this analysis, has been contributing to that 8%. So that's why we did this analysis to show that actually this 38% in the next coming near future, there might be a decline, right? But then the decline will be aggravated and accelerated by the USD executive orders. I know Washington, D.C. Is quite unpredictable as days come, but USID is causing a huge ripple effect. So USID for sure, USD, USID, PEFA, for sure, there'll be decline in all country programs and investments that they have been doing. So that's the first ripple effect. A huge chunk of the countries depend 40 to 60% of their health budgets to USID, to be quite precise. And over the few years, Sub-Saharan Africa has been receiving the biggest share, but then due to Ukraine and even Israel, there's been a bit of shift whereby Europe and a bit of Middle East has been received a good share of compensation in the last 3 or 4 years or so. Since the Biden's administration and now Trump's administration, we foresee more investments going into actually even Israel. Another aspect I want to recognize is that, and I did mention this, you did put in all funders that are money is coming from USG, Global Fund, UK. All these instruments depend on USG. USG contributes and is the biggest contributor across the Global Fund, Gavi, WHO, all UN agency, and World Food Programs, even beyond even health, to even aspects to climate as well. So there'll be a significant reduction, and that's why we did this exercise. There'll be a significant reduction in replenishments for all these initiatives. And then finally is the debt and the conversation we had with China, right? USD contributes significant amount of money to World Bank, IMF, and Africa Development Bank. They come in to cushion governments, right? When, like, for instance, COVID time, right? Post-COVID time, IMF and the World Bank put in significant amounts of money into the healthcare systems, right? So even at times when there's high kind of payments that are going to debt, they do come up and cushion governments. And this cushion is what it requires for us to at least get more funding to the health sector. GDP ratio to debt is around 59% on average. So again, not a good picture as well. So again, with USD, World Bank, IMF, and USD will be significantly impacted, and so will be governments who are also dependent on those instruments to get a bit of soft loans, really, that are not that competitive or commercial, such as China. And lastly, you've seen all in the news, is across all other external partners, right? UK, MP Starmer recently, just after announcement of USG freeze, did mention that they'll be putting more money, right? Less external aid and more into their military. You've seen Switzerland. These are snapshots of the news, right? Switzerland as well, significant contributors to the UN agencies. They've said they'll be cut down the external aid 2025 and onwards. Another one is Europe. France also did mention that. So there's a huge ripple effect that's happening with geopolitics involved. Unfortunately, we are being affected and will be affected. This pie chart will look so worse in the next coming few years. And that's why they need to have such conversations, right? At core, we need to find really cost-effective, right, initiatives, approaches, community health rather to really help us cushion ourselves against this, and also just ensure as well the health systems are operational, both domestically and even from external investments. That has been my time. I'm hoping I've planted a seed. I'm hoping, I'm told that I got feedback that I'm quite, I never lie, never, no, I tell what it is. So I'm also hoping that I've given you a reality for you to reflect in and outside this room, right? In and outside these engagements, even as you go back to your duty stations and home country. I'm hoping that I also set the scene for today's discussion. I do really appreciate that. Has been my time. I'm Dennis Mugote. Do really appreciate, and thank you so much.
Thank you, Dennis. That was a very engaging conversation. Wouldn't you agree? Yeah. So we are going to open it up for questions. Maybe 2-3 questions from the audience.
Mine is a comment, actually, not a. And thank you very much for the presentation. For the tracker that you showed, the progress across the various countries, something really struck me. Most of the countries that have the greens and the amber, you will see that the spending by the government is also higher. So I think that's a good sign that the more governments put in their resources into this, the more progress we're likely to make. Thank you.
Thank you. Thank you so much for the good presentation. Yeah, I'm trying to think about this declining of external funds. Yeah, I think it's not the first time we are talking about it. A lot of narrative are talking about it, especially in sub-Saharan countries. But African also, it seems like they are there to alarm, and then there's no real concrete improvement about it. I don't know if in next 5 years, 10 years, we'll come back again talking about declining. And the big problem is that most of African countries, they are even not able to, let's say, to cover what has been discussed a long time ago about Abuja Declaration, 15%. And I'm still wondering, African countries will continue to complain, to alarm, and then what will be the next? What can we do so that we can improve our system? When we are talking about private sector, for example, even the private sector, if you see the way our private sector is growing, it's good, but the investment is still low. Yeah, I think we need also to think out of the box how African country can improve their investment in health, and we can innovate even. How can we innovate so that we can increase it? Because talking about declining of external funds, we'll continue complaining. Thank you.
Thank you. There's one question there. Thank you for that. Please introduce yourself as you ask the questions, please.
Thank you. So my name is Stephen Mulupi. I'm a researcher, done a bit of health financing from Nairobi, Kenya. I'm currently head of research at LVCT Health, national NGO in Kenya. So listening to your presentation, thank you so much, Dennis. And there's so much insights there. But what strikes me is, one, there's a huge global dependence on the United States government. Even when you look at European countries, you realize that when Trump now says that he's going to cut down funding from NATO, it means that there must be a shift, because most of these organizations or countries were depending on United States funding. In terms of what we can do at home, from my perspective, there's a big issue in terms of governance, in the sense that we create institutions, the rules, and that shape behaviors of the different actors in terms of incentives and sanctions to drive more meaningful domestic spending. Because when you look at context across Africa, you'll find that there's a lot of wastefulness in terms of even the little or the scarce resources that we have. So how can we have a conversation about, say, depending on PEPFAR funding for 30 years on HIV, which is a very critical public health issue, and we do not give domestic funding like priority? So there's need to be a shift of mindset in terms of what's happening at the governance level, in terms of how our political leaders are making decisions. And when you look at the chart you shared, there's a story there about political decision making. If you talk about countries like Rwanda, in terms of South Africa, we could juxtapose what political leaders are doing, what their priorities are, how the institutions are working in those countries, and see what kind of lessons we can take from there. Thank you.
Thank you.
Politics is everything in government. Politics is how money is spent. Politics is how money is generated. Politics, by the end of the day, run the government, right? And we can't operate at an island, right, without engaging politics, even in the health sector, right? Again, how do we create initiatives as well that brings good political goodwill? How do we engage in the legislative arm of the government? How do we engage in the executive arm of the government? By the end of the day, you've seen politics, geopolitics, right, has left vulnerable dependent households, right now, right, without access to, and it's the geopolitics that happened in Washington, D.C., right? And I mean, I lived to town, right, in Tanzania, but I've been affected, right? So politics and geopolitics are everything that we run, and we need to ensure we interweave all our interventions, factor in politics, and how do we run and more of map out and ensure that politicians and political decisions are also part of our engagements and our plans. Thanks. But amazing point. That's true.
Okay. Thank you so much, Dennis. We're kind of running out of time, but if you'd like to have further conversations and engagements with Dennis and our team here, please feel free to do that. Now we will get to the next session. First of all, how are we feeling? Right? How are we feeling? This crowd is hard, man. How are we feeling? Good? Okay. So I don't know if you went to church, but my pastor used to say, turn to your neighbor and ask them how you're feeling. Come on, turn to your neighbor. If you don't turn to your neighbor, I will come to you. Come on, yeah, you can even high five. In church, you normally high five your neighbor. Yeah? Awesome. You guys are fantastic. So, okay, so we'll get to the next session. After this, we'll have a tea break. And I'm honored to invite Kandie, who's a health financing technical advisor in Kenya. And she's going to be speaking on community health financing landscape in Kenya, just to give some context of what is happening in my country. Let's see how that is going. Welcome, Kandie.
Thank you, Wendy. I think I'm feeling a bit depressed looking at that, the trends in terms of financing. And if you're not deliberate about investing in public health, then I think we are in for trouble. Just a moment, I load my presentation.
No, you're not a why am I not a
Okay, so let's do this. Let's reach.
Let's ask.
Go ahead. Go ahead. Come on. Go down. Let's see who are the people in the room. Not the people going down. Ah la la. And we're in the health space. Ah la la. Come on, let's stretch. Again. Okay, that's enough.
Thank you. Not yet. It's still trying to load my presentation. But thank you, Dennis, for setting the pace for this workshop today. And just to mention that the picture that Dennis has painted is no different from Kenya's financing landscape. And I think we really need to think about our own solutions as Africans so that we're able to finance our healthcare system. Otherwise, with this withdrawal from USG, my immediate thought were, will our indicators, our outcome indicators decline, especially for our maternal mortality ratios, our neonatal mortality rates that are not doing quite well at the moment. My question is, what are we going to do for us to sustain or improve on our indicators? So may I quickly shift to Kenya? I want to give paint a picture of how Kenya's community health financing is. This focused on community health financing. And please change. So last year, between November and December, Financing Alliance for Health attempted, or we carried out, a health financing landscape analysis of community health system in Kenya. And today I want to share or help us understand how does our landscape look like. So I think it's coming up. Thank you for your patience. Okay. I think I can't overemphasize enough that health is a basic human right and also a determinant of growth. Those two go hand in hand, health and economy, they go hand in hand. And in Kenya, we have a devolved government structure. We had our constitution promulgated in the year 2010, where we moved from a centralized structure or form of governance to a devolved form of governance, where we have the national and we have the subnational level. So we have the national having its own mandate, as you can see, and we have 47 subnational levels in Kenya, governed by governors. And each also has a role in terms of investing in equitable and high quality health services without discrimination. And we recognize that community health system, and if I broadly talk about primary healthcare, is very integral in the achievement of universal healthcare coverage. We all have, and I think globally, in Kenya, we have this ambitious goal to walk the journey of universal healthcare coverage. And so we can't ignore that community health is very important. And so what should happen, I think Dennis has talked about sustainable resourcing and also ensuring that community health is integrated into the broader health financing landscape. And so it is the role of the government and even developing partners to also align with national priorities and policy commitments to ensure that our community health system is well resourced. So talking about priorities, I just wanted to share what are our priorities in community health in Kenya. And we can see that we have around 5 strategic objectives, starting with strengthening management and coordination of community health governance structures and creation of a platform for strengthening partnership and accountability. Then on the third bullet, we have increase of sustainable financing for community health. Our strategy is coming to an end this particular financial year, and it was costed. The cost was around 41 million USD. And what we are seeing is that when we go into the next development of our strategy, we might have the cost of implementing community health in Kenya increasing, because there has a lot of changes in the community health landscape in Kenya in terms of even expanding the services that community health are offering right now. So one of the key changes in Kenya is, say, the introduction of the ECHIS, that is the Electronic Community Health Information System, which the community health workers are using in terms of data collection. We have also community health workers offering some for preventive and promotive, and to some extent, referring patients of the households to the spokes, that is the health centers and dispensaries. And that has to do a lot with household visits. And we have now our CHPs, the community health promoters, provided with what we call the community health promoters kit. There are a certain number of commodities which will be used, or they are using it when they are seeing the households. So we anticipate that the cost of implementing community health in Kenya will be higher than what had been costed in this particular strategy, the 41 million USD. And we also know that, tying it to Dennis's conversation, is that we have to think of how to finance that strategy. So because you're going into it. So far we've had achievements in Kenya since implementation of this particular strategy. And I think I've talked about the professionalization of community health promoters through remuneration. What the government has done, or is doing currently, is incentivizing community health promoters. So we have what we call matching. So this national and subnational level have come into an agreement where they are paying per performance. So the national government is paying, how much is 2,500 shillings? $200, $2.50. No. $25, and the subnational level is paying $25. So that is $50 per month. But that does not match what Denise was saying. $20. So whatever the community health promoters are doing cannot be matched with what they're getting. But if, nevertheless, what they are doing currently, I think in terms of incentivizing, that is a commitment that the Kenyan government has done. And then also we have the provision of the community health promoters kits. Currently, the government is financing around 100,000 community health promoters. But we have, in our database, we have around 107,000 community health promoters serving the entire republic. And we anticipate increase of community health promoters. So what does that mean? If you enroll a new community health promoter, it means that you have to invest in buying the kits for them. Also, we have, in terms of upskilling community health promoters, I think what we've done in Kenya is develop the basic modules and also what we call the technical modules. Because if you look at the curriculum for community health promoters, we have modules like management of, say, community health, non-communicable diseases. We have the cardiovascular diseases like diabetes, just for them to be able to do the screening so that they're able to refer them to upstream to the health facilities. And so we are seeing a lot of training going on, and with a deliberate effort to ensure that all the CHPs have at least a skill to be able to serve the households that they are deployed in. And also the government also has rolled out the community health information system in all the 47 subnational levels. They've led in this work. And also with this, they have provided around 100,000 smartphones for the community health workers, for the community health promoters to use them. Before, they used to use the manual, the manual registers. They would carry them as they go for the household visits. But with this shift in terms of digitization, so we are seeing that all the community promoters have been supplied with smartphones. And so what are we saying? And I want to reiterate that sustainable financing mechanisms are very key to bridging what we talked about in terms of the gap in financing for our health system and more so community health, so that we're able to see a long-term or support for community health implementation. And I think, Dennis, we talked about insurance, we talked about private sector. There is largely what the government should do: domestic investments, domestic resource mobilization towards community health implementation. And so for us to be able to sustainably finance our health, our community health system, it means we need to understand our landscape. What is our resource envelope, for example? And so for this particular evidence we'll get from understanding our financing landscape, we'll be able to identify and monitor our funds flow, assess our funding or assess the gaps in financing, and facilitate evidence-based advocacy for resource mobilization and reduction in donor reliance. And so we needed to undertake a comprehensive and standardized resource mapping because we have, a comprehensive and standardized resource mapping is a challenge with gaps in data completeness, alignment of financing with needs, and coordination across the stakeholders. So in Kenya, what we realized is that tracking and mapping resource flows to community health is a bit complex, or is complex, due to the fragmented nature of funding sources. We understand the mix of funding or financing for community health, whether it's from government or from donors or from private sector. It's so fragmented that tracking and mapping these resources is complex. And also in Kenya, we lack a standardized financing reporting mechanism and a limited transparency in financial data, especially from non-governmental stakeholders. So this is where we really have a challenge in Kenya in terms of tracking and mapping of our financing resources. And so we see this complex nature complicating our effort in terms of analyzing our financial information and hindering effective resource allocation. So I talked about us running an assessment last year between November and December, and we had some set of objectives, and one of them to systematically analyze the funds flow, also to evaluate the adequacy and alignment of our resources in the community's health space, and also generate insights to guide the Ministry of Health and stakeholders in making strategic decisions, and also as AfHEA attempt to develop recommendations for sustainable financing models. So what I'm showing is just the approach that we used. And so started off with tool design and also stakeholder mapping. So we needed to identify the key stakeholders or the key actors involved in community health in Kenya. Then we were able also to engage our division of community health, because that is how the organogram is in Kenya, where we have two state departments. We have the State Department of Medical Services, and where community health sits is the State Department of Public Health and Professional Standards, under the Department of Preventive and Promotive. And so we engage the division, and also we have an ecosystem, what we call the Community Health for Universal Healthcare Coverage ecosystem, where we also did conduct a training for the ecosystem on how to use the tool. Thereafter, we shared the tool and we collected this data between November and December. We synthesized, and now I'm here to share what we were able to collect and collate and analyze. So there were some limitations, and I think probably it resonates with our countries. We shared this tool to the various stakeholders, and it was a self-assessment tool. And one of the limitations is that the self-reported data from the implementing partners were not consistent. You find that there were parts that they were populating, some parts were left out. Then another limitation that we really encountered was delay in submission of the data by the respondents. We also had data gaps because in our tool, we wanted to see data 3 years back and 3 years, that is 2025, 26, 27, what was projected or committed for community health system. But the data that we got, we did not, we're not able to appreciate the projections for future funds. And also, being that we have this structure that I talked about, the devolved government structure, we were not able to do an assessment comprehensive enough for us to capture the critical budget lines within the government, county government budgets. We know that we might have captured the donor, but we have government allocations towards community health, which we were not able to collect because of the time that we took in terms of data collection. And so what we're saying is this, that the findings might not really fully reflect the overall resource landscape in Kenya. So out of the 43 stakeholders reached out, the response rate was 51%. So this is just to show the outline of the results. And I think I'll go straight to the first result, and that is we attempted to understand the financing sources and flows. And I think I will not delve into the sources because we've largely looked at where does our envelope come from? And we know we have government, we have bilateral governments giving us aid, we have multilateral, and we have private sector and philanthropies. But this is how the funds flow look like in Kenya from the national to the subnational level, that is at the community level, which is an equivalent of a level 1. Probably I needed to talk about how the system or the health system is organized. Beyond now the devolved governance, we also have a tired kind of a system where we have the 6 levels of health. So we have level 1, which is the community health. Then we have level 2, which is the dispensary, and level 3, which is what we call the health center. All the 3 levels now from primary healthcare. And then now we have the level 4, 5, and level 6, which form part of the referral for the county and also at national level. So you can see that we have captured largely in this diagram that Dennis had tried to see if we can demonstrate the aspects of fiscal pie. We still have the donors bringing in money into the health system in Kenya. We have the national government, and then we have the Social Health Insurance Authority. I think we had significant reforms in Kenya in 2023, where we moved from the National Health Insurance Fund, and now we have what we call the Social Health Authority. And under the Social Health Authority, we also have some 3 funds that have been set up by the national government. That is one, we have the Social Health Insurance, we have the Primary Healthcare Fund, that is specifically to finance primary healthcare, and we have what we call Emergency Critical Care Fund. And I think that is detailed in our laws that have been published in the website of the kenyanlaw.org. So money moves from donors, and I put their special purpose account because we have donors whom will bring on budget, off budget, but on our budget in Kenya. And actually one of the conditions is to put money into a special purpose account. An example was Danida, where we had money coming in, but now it has to go into a special purpose account. Of course, that's a condition, and there are best reasons why money has to move. And then we also have donors who would now give money or support or in-kind support directly either to the health facilities at the subnational level or to the community health services level 1. To note is that during our mapping, we also realized that because of our poor tracking of our stakeholders, we also had donors or implementing partners who would finance the subnational level without the national government appreciating who works where. And that is why mapping of our stakeholders or who we work with and understanding our envelope is very important. Then we have the national government, where every financial year we have a budget for the equitable share to the subnational level, the 47 subnational levels. And they're located, I think, a total of around 86 billion every financial year to the subnational level, and that is shared according to what we call the county revenue allocation. There's a formula that they've used to ensure that these counties are also financed equitably. So once we get money into the county government, they have an account they call the County Revenue Fund, where that money comes into. And another thing I want you to understand is that within the county systems, they also collect their own on-source revenue, either through taxations. You can have licensure maybe of eateries, we have parking charges and all those that we normally collect money from. And that money is collected into this county revenue fund. Then the county government also does, they have their own autonomy to allocate this particular money that they receive from the national government, combined with on-source revenue, now to the health facilities. So we have all the sectors that have been devolved into the county government, financed by the county. And the county now, focusing on health, will finance the county department of health, because all the counties have county departments. And these county departments, largely we look at into financing inputs such as salaries, we have equipment, infrastructure, et cetera, and also we find that some counties in Kenya do direct facility financing, where they send money to their health facilities either every month or every quarter for them to be able to take care of the operations and maintenance. We also have money flowing. Now looking at community health services in Kenya, we have money allocated from the County Department of Health to the level 1, and basically 1 is to pay salaries, because we have the community health assistants who manage the community health promoters, and we also have money going into supporting operation and maintenance within our community health system. So a provision of stipends and so on and so on. And I think we can appreciate this. So on to the second area, on just generally, how does our government budget allocation to health looks like? The Ministry of Health undertook a review after devolution to 2023-24, the financial year 2022-24, just looking at how is our financing trends. And we see that government has increased financing to health by around 258%. That is 78 billion to around 280 billion in the financial year 2023-2024. But then now if you look at the county government, that is in blue, so they have largely increased, and we have the national government, the 141 billion. But just to inform the participants is that if you look at how government allocates its resources, or the Ministry of Health, is that much of it will go into salaries for the officers working at national government, and a bit into now the sagas, or what we call the semi-autonomous bodies, and just a small fraction to capital expenditure. But for the counties where the money is needed most, because they are directly financing community health services, you can see how much they've been allocating over time. So from the assessment that the data that we collected, and if you look at the various funding sources, you realize that in the financial year 2024, from 2021 to 2024, the total estimated community health investment was around 362 million US dollars. And this was largely from the 5 funding sources. And you can see the purple being the subnational government has decreased over time from around 68% to 21%. And if you look at the blue, the national government, the increase was from the money that they are channeling towards the community health stipends and to the buying of the community health kits. So from the projections that we wanted to understand, there is generally a declining trend, and you can see that investments in community health has dropped from we will be dropping from around $101 million in 2020 to 83 million in 2027. And so this signals a potential funding gap. And so this is a wake-up call for us to really brainstorm and ask ourselves, then how do we sustainably finance our community health? So from 10 implementing partners, we wanted to understand, now with the money that they get, so how do they spend that money? Or what is the breakdown of the investments by programmatic area for the last 4 years? And we can see that 83% of that money is allocated towards community health worker service delivery, and 6% to technical support, and in terms of advocacy, that is 1%, quite low. So we can appreciate where money goes in Kenya. So in summary, in terms of challenges, one, it stands out that we have inadequate domestic funding and over-reliance on donors in our community health systems in Kenya. And I also want to talk about the challenge that we have in terms of advocacy and decision linked to this limited integration of community health into the broader primary healthcare financing frameworks. Because of how our organogram looks like, where we have, under the primary healthcare department, we have several divisions, and none of them is community health. So we don't have a nexus with all the other divisions to just discuss. And when you're talking about primary healthcare financing, then we need to have community health as part of the items being discussed. And then because of the limitations, so another challenge is weak resource and expenditure tracking within government, which hinder effective evidence-based planning and budgeting. And also I talked about the legal frameworks. I talked about the Social Health Authority. We also had another one called the Facility Improvement Financing Act, and we have the Primary Healthcare Act 2023. As much as these legal frameworks mention on the provision for community health financing, we do not have an explicit clause to guide us on then how does money get to community health? Because if you look at how SHA operates, money, or they contract providers. That is, it is level 2, level 3, and that money goes directly into the accounts. So the mechanism as to how that money goes to or is allocated to the community health space is not really very clear. And then lastly, we have weak frameworks to align donor funding with community health priorities due to the fragmented nature of community health financing in Kenya. So some of the recommendations from Financing Alliance is one, we need to increase domestic budgetary allocations and develop some of the financing, sustainable financing mechanisms. And I hope in the panel discussions, we're able to touch on what are these innovative financing mechanisms that we have introduced in Kenya. We have resource allocation should be guided by evidence-based needs rather than political consideration. Why I put this here is because currently we have the community health stipends being paid by the national government. I'm hoping this will not be taken as a political statement, but looking at what is happening is that the current administration came in with this, they have what we call the bottom-up transformation agenda, beta agenda, where universal health coverage is their 5th agenda. And community health work has really gained a lot of traction because of that political goodwill. So what we're afraid about is that, for example, if the payment on stipends is based or has been factored in by this particular current administration, so what if the administration goes out? That will it mean that it will stop? So we really need to look at how do we then resource share according to evidence-based needs rather than political considerations. And then I talked about the integration of community health into the broader primary healthcare financing frameworks at both national and community health level, so that county level, so that as primary healthcare discusses about PHC financing, community health also is on the table advocating for their own resources. And then institutionalizing financial resource tracking, I think is very important, and have a standardized mechanism for reporting for both government and non-government actors. And then lastly, because of the limitation of this particular assessment that we undertook, we also recommend that we undertake a more comprehensive resource mapping where we are able to put together all the data from both the national and the subnational level. And so that has started. We have met with the national government because the challenge that we found out is that in Kenya, if landscaping or resource mapping is led by an implementing partner, we do not succeed. So now we met with the national government, and we are now on course to undertake a more comprehensive resource mapping. We've come together with partners like CHAI, Clinton Access Initiative, who are also had a plan to resource map for government. We also have another actor that also is interested. So we've come together and to see that we undertake this particular resource mapping, and then have the government lead the process. As it is currently, it is housed in the Division of Planning. And we formed the data collection team. And by April, 1st of April, then we'll be going into collecting data from both development partners and government. And also of importance is that for our resource mapping, because if you look at how we did our landscaping, it was not really aligned to the government budgets. But from our meetings, we've agreed that the indicators that we have selected are going to be aligned to the government budget to ensure that we have standardized data that is comparable. So we want to compare apple to apple in our mapping. So lastly, talk about the use case for this. Oh, sorry, the scope. We're going to focus on budget data, and it will be in a phased approach. So the first phase will be the major donors, so that we avoid duplicity, because if we collect data from both donors and implementing partners, then we risk duplicity, and then national government. Then in the second phase, we'll now go down and collect data from the 47 subnational levels. And so the use cases, as you see, one is to provide evidence to advocate for increased investments in priority health sector areas, also identify the funding gap, and guide strategic reprioritization of financial resources. And lastly, also to develop a long-term sustainability and resource mobilization strategy for the country. So I think because of time, I won't go through how our tool looks like, but it captures, it's as comprehensive as possible for us to capture what we need for us to be able to drive the agenda of advocacy. So I want to thank you so much for listening to me and open this up for Q&A.
Thank you, Kandie. I think we can provide a round of applause again to Kandie. And as now we are moving, we can see how we are now linking from Dennis' presentation, the whole macro presentation, to country-specific reality. So we can move now to the next session, which will be the question. So if there are some question here, and I already have seen one hand here. Thank you. So you can just introduce yourself and then you.
Thank you, Kandie, for the great presentation. My name is Dennis Ngonda. I work with the Ministry of Health here in Rwanda. First, from the challenges or limitations that you showed, I just wanted to provide an insight on how, as moving forward, the mapping, resource mapping, partner mapping, it's something you can learn from Rwanda. The Ministry of Health, we have a unit which is called SWAP. SWAP is a sector-wide approach. So it does all the mapping for all the partners. So in that way, there is, we avoid overlapping of partners whereby each partner comes and wants to invest in maybe in nutrition in the same area where there is another one. So there is that mapping which is done by that department. So there is should I say, equitable resource allocation, and also follow-up of partners, what they are doing in which area of intervention, because all partners are also required to, before they are given or before their MOUs are renewed on an annual basis, two-year basis, I think, there is the health resource tracking tool, the HRTT, which they are required to be reporting. So there is easy follow-up of partners and resource allocation and everything. Yeah. So just moving on to the few questions, I just wanted to know, because in Rwanda we are also implementing the community electronic medical records. We have started piloting. We are moving on to scaling up. I just wanted to know what is the strategy for replacement of the devices, management of the devices. You know, these are smartphones that get stolen, that, you know, there is all that. So what kind of strategy do you have in Kenya so that the program is sustainable? Then you talked about the devolution and what is the uniformity of the counties implementing national programs, the national health strategic plan and other programs? What is the kind of uniformity? Because each county is implementing on their own. So isn't there like a problem in implementation and ensuring that the government gets a uniform outcomes, health outcomes within the country? Thank you.
Thank you so much, Kandie, for that presentation. As I said, we are leading research in Kenya, and we are also working on research to look at mental health and well-being for community health volunteers in Kenya. And there's a big aspect of stipends, community health financing there. So my first question is this, maybe to just paint a picture that stipends, community health promoters are given 5,000 Kenya shillings stipends. That translates to about 38 USD per month. That's what the current policy provides for. But emerging research findings are showing that there's a bit of problem in terms of delays, in terms of disbursements. So there's a question there about the reward aspect of that stipend. But most importantly is that everybody who comes to communities always think that their problems should be solved by community health volunteers. So if an external organization has a project, who do we access? Community promoters. If it is immunization, we saw what happened during COVID-19, and suddenly everybody remembered that community health promoters are really important in driving important control measures. My question is about fairness in compensation of community health promoters. So in terms of, you mentioned a very important bit about relooking at the gap. In this case, are we thinking about what a fair level of compensation should be? Because if I pose a question here about how many people here can take 40 USD for a month, how many can accept that? So there's a big question there. And of course, there's a story about them being volunteers, but we reject that because there's the story about also exploitation of people's times and labor. So how much is a fair compensation threshold? So is this a question you guys are having when you're going to the next phase, so that when you're looking at the gap, you're measuring it accurately? I think my colleague from Rwanda, they raises an important question that resonates. And I think there is opportunity to link in terms of what is happening at ICHIS, our Community Health Information System, because already there are rumors about unintended consequences coming out of that financing. For example, landlords increasing rent and saying you guys are now being paid, so the rent is going up. Question coming back to what is a fair compensation? Thank you.
So maybe I can answer that, and also if not well exhausted enough. I think Dorothy, my colleague who supports really the subnational level, also shed light on what is going on with the next level of governance. So maybe I'll start with Dr. Mulupi's question. Are we looking into a fair level of compensation? I can say yes or no. This is a discussion that is really, it's a really mind-boggling discussion, being that if you look at the cost of paying community health workers as it is currently, we can say it's not even sustainable because we still have counties that don't even pay the CHPs, even though the national government is currently, although delayed, is paying the community health promoters. So I think what we are thinking as Financing Alliance for Health is then what other mechanisms can we use to see how these community health workers can be empowered, for example, and I think it's going to be shared, and that maybe will go into seeing that these CHPs get their fair share of compensation for the work that they do. And I think I just want to add that I think if you look at the expanded role of community health workers, it's really heavy on them. And also, we have the community health, the social health insurance registration also being done by the community health promoters. So we appreciate the fact that it's really heavy on the CHPs. And this discussion is ongoing, and we don't know when it's going to mature to the level whereby we are able to compensate these CHPs according to their performance. I know that currently the discussion is that the compensation, whatever little that they're getting, is based on performance, but really, I don't think it's fair enough, Dr. Mulupi. So we are here to brainstorm as AfHEA and ask ourselves that question that you've asked me. So what do we do in terms of compensation of CHPs? And I think the case, I mean, in all other countries where they call them the community health volunteers, what do we do as an African, the African state, to be able to see that our CHPs get fair compensation? We've talked about the problem in terms of the itches. Dennis has talked about itches and what is the plan in terms of replacement for the ones that are lost. And indeed, as soon as we started or they were distributed, these smartphones, some of them are also reporting that the smartphones are lost. So, but there are discussions, national government, on how then can we replace or rather have the subnational level, because the support for smartphones is by national level, but the current discussions is how then does the subnational level support the replacements and also maintenance of these smartphones, because it's quite complex, or it will not be sustainable if the national government does that on their own, because at the end of this, I think 3 years, that shift in terms of taking up the burden to ensure that these CHPs operate efficiently, we rely squarely on the county government. So that discussion is live on how that transition can take place. I think in terms of uniformity, what is the uniformity of? Okay, one of the major challenges that we see in Kenya, and I really like the system in Rwanda where we have the swap, and also I think in terms of managing implementation is more organized. I think for us, being that the mandate of the national government is, develop these policies and frameworks and, cascade them down for implementation. One of the major challenges we're seeing is in terms of now the national government coming down to give TA or technical support to the counties to ensure that these strategies are implemented. Because if you look at the budgetary allocation for national government, it basically goes to salaries and maintenance, things like printers and whatnot, transport. But we don't have a budget line dedicated, because for them to be able to now dedicate time, because there's money, for them to be able to support the counties to implement the strategy. Two, we also have a challenge in terms of regular monitoring or performance review of our strategy. And so we are not able to appreciate in terms of progress. How are we in terms of, so this is our 5-year strategy. So year 1 of implementation, where are we in terms of, where are the counties? So some of the challenges that we're having in Kenya, which we are trying to see then, how do we, as we move to the next strategy development, how do we institutionalize tracking our M&E framework to ensure that the counties implement the strategies as it is. But from a financing alliance, for the counties that we work in, we are really trying to see how, because as a national strategy, we have it cascaded down to the counties that you're supporting. And us being present, we're able to monitor and see then how is the implementation. I think, Dorothy, if you have anything you can add on how the counties are, we are good. So. I don't know if I've answered the questions exhaustively.
Dennis, Kenya is a devolved system. And the reason as to why we devolved it for us to customize services according to the need of different population. So we don't necessarily have to implement the community strategy uniformly, but we are supposed to allow the county governments to customize the policies and legislations and the strategies to implement according to the need of the population. Then, despite the fact that you are saying it's a small stipend for Kenya, $38 per month, community strategy in Kenya started way back 18 years ago. 18 years, yes. This is our 19th year. But they were compensated for the very time in 2024 after 18 years of existence. So we appreciate the government has made some baby steps. So what we are doing is we are supporting them to get other innovative financing mechanisms to support, but also supporting the government to minimize wastage, because I think that is where the rubber meets the road in our governments.
Okay, thank you so much. I know we still have some question here. Let's just take 3. Okay, Shivani said no, she's the manager, the time manager. So now, okay, she is suggesting one thing. Guys, remember we still have a breakout session where we will discuss all these questions in practical ways. So let's size this or the opportunity, because the coffee break is going to be removed. So we can just go for 10 minutes, 15, 20 minutes. Oh, okay. Okay, the boss has said 25 minutes. So let's go for 25 minutes. Then we come back for this, the panel discussion, where now we'll have enough time to ask questions and very practical, because Kenya is still coming back on the stage. Thank you so much. Enjoy your coffee, tea. I don't know if they are porridge, water, whatever is there. Thank you so much. Bienvenue dans la salle. I just want to test the translators, if they can move from French to English. And now we are ready for the next point on our agenda, which is the panel session on innovative financing mechanisms, which are being implemented in countries. And Gaia is going to be our moderator, and I'll pass the floor to Gaia to introduce the panelists. Thank you so much, Gaia.
Okay, good morning, everyone. It has been an exciting engagement so far. I hope everyone is having fun. Very excited to be here with you. My name is Said Gaia. I'm Health Financing Technical Advisor at the Financing Alliance for Health, and I'll be the moderator of this panel. So, Shivani, are we ready to go? Okay, good, brilliant. So without much ado, I will be introducing the panelists. Already we've had we started conversation on community health and community health programs in Africa. We're taking a touch of what is happening in Kenya. Now we'll be hearing from the horse's mouth, okay, from government who are working firsthand, to implement these programs, to the community health workers who are on the front line doing this work every day, to also technical experts who understand dynamics around these programs. So without much ado, I have the honor to introduce our panelists. First is Mr. Dennis Nkunda. Mr. Dennis is a community health expert in Rwanda's Ministry of Health, He's particularly interested in advancing universal health coverage and health equity through community health program and also performance-based financing. He has contributed to leading health journals and provided technical expertise across Africa. He's passionate about primary healthcare, health financing, and digitization, and also advocates for public-private partnerships. So ladies and gentlemen, please join your hands in welcoming Dennis Nkunda to the high table. Thank you. Please go to the stage. You're welcome, sir. Next, we have persons like Dennis had mentioned earlier in the day who are actually the backbone of the health system. They often go uncelebrated most of the time. You know, so we are very excited today. We have Magnific Beatrice. I hope I pronounced that correctly. So Magnific Beatrice is a community health worker who is passionate about serving her population. She has dedicated over 3 decades, okay, of her career to saving lives in her community and has played a big role in ensuring the well-being of mothers, newborn, and children. Please, let's celebrate Beatrice. Let's celebrate her. They're often uncelebrated. Thank you very much. You're welcome, Beatrice. Next, all the way from West Africa, we have also another seasoned public servant. Her name is Ami Mbake. She has been dedicated to community health. She's a community health professional with experience in Senegal's civil service, okay, NGOs and academia. She holds a bachelor's degree in community health and a state nursing certificate. She has participated, since 2013, she has worked in the Ministry of Health and has participated in the development or has led development of national policies, including the National Community Health Policy and Strategic Plans. You're welcome, Mrs. Mbake. Thank you for coming on stage. Last, we have, but not the least, is a very powerful woman. I'm very happy today that this panel is very gender balanced. So we have one of our own. She's a senior health financing technical advisor at the Financing Alliance for Health. She's Kenyan, by the way. So we started to hear a bit about Kenya. We'll hear more about it. Her name is Dorothy Wavinya Mgwe. She's passionate about connecting public health finances to improve quality service delivery. She has a lot of experience working, supporting government in Kenya to achieve, to strengthen community health systems. You're welcome, Dorothy, to the stage. Thank you very much. Yes, so without much ado, I'll sit and I'll be the moderator of the panel. What is going to happen is that I'll bounce the questions across, and then after we are done, we'll have a session or opportunity for the audience to ask some questions. You want to say something? Okay. All right. So, thank you, our esteemed panel. Without much ado, we would commence. Mr. Dennis, I want to start with you. Okay. So we've heard about, the conversation started with universal health coverage. And Dennis had even shown us sort of a heat map about how Africa is, progressing towards universal health coverage. But we often hear, in the literature sometimes about how, Rwanda has been an exemplar. How Rwanda has been an exemplar, in achieving universal health coverage. And we know that, it has made remarkable, it has made strategic investments in primary healthcare. To transform the health outcomes. So can you just share, with us or with the audience, how the community health worker program in Rwanda has evolved and how it has impacted health outcomes? We'll be very happy to hear from you, giving you a wealth of experience working in government.
Thank you, Said. Good morning, everyone. First of all, I'm happy to be part of this panel to discuss an interesting topic, which is innovative mechanisms to financing the community health program. I think from the start of this session in the morning, it was all about financing, sustainable financing. It was all about, bridging the gap. So, going to your question, Rwanda has been able to achieve various global health targets, courtesy of community health workers. I think every different speakers in the morning started by saying that community health program is the foundation of UHC, of primary health care, of everything, because if you don't have a strong primary health care system, which begins with the community health program, then you won't be able to achieve the various targets. So going to the overview of the community health program in Rwanda, first of all, it started over 30 years ago in 1995, just immediately after the genocide against the Tutsi. So since then, it has been evolving. It started with 12,000 community health workers. It went on evolving. So the way it evolves depends up to today, after over 30 years. It evolves depending on the needs. What are the needs that the population that the population have? And then government says, okay, let's add this package, let's add this package. So in the beginning, it began with community health workers being there to provide psychosocial support, you know, after the genocide and everything. So with more needs coming up, there was a lot of task shifting up to today. There is task shifting whereby community health workers go on supporting. So currently we have close to 60,000 community health workers who serve the population, and we have 4 community health workers at every village level. So to put it into context, village in Rwanda is the lowest administrative level, because from village you go directly to household. So we have 15,000 plus, 15,400 villages in Rwanda. So, which means that we have 4 community health workers who are supposed to serve the households in that community. So they provide different promotive, curative services to the population. So like I said, the program has been evolving. Now currently we are talking about the service package for community health workers is about, I think it's now 16 packages. And it began with 2 or 3, so it kept on evolving. So they provide briefly services on maternal newborn health care, nutrition, family planning, gender-based violence, first aid, non-communicable diseases, so different HIV and AIDS, HIV, TB. So it goes on evolving with the needs. The most recent being first aid and non-communicable diseases. And before that, during the outbreak of the pandemic, of course, there was another task shifting whereby the health facilities were getting overwhelmed and all that. So there was that task shifting so that the not so bad cases, those that don't need air, they can go back home, and then community health workers can continue to provide home-based care management for those COVID patients. During the outbreak of the recently of Marburg, there was that. So they provide a whole range of services. Now, with all those services that we've seen, and more actually, you find that all the results, all the statistics that we see, the reduction in malaria cases, reduction in maternal mortality, neonatal mortality, improvement of child health, all those services, community health workers have got a very big role that they play in improving those. For instance, I think from the recent malaria report, we saw that community health workers had managed close to 45% of the malaria cases were managed by community health workers. So all those impact the health outcomes of Rwanda in terms and all the indicators that we are able to achieve, even the ones that were being projected here, maternal mortality and all that. Community health workers have got a very, very big role that they play in that. Yeah.
Okay, thank you so much, Dennis, for those insights. It's good to know that community health workers are playing a critical role for health services to reach the last mile in the community. So for Madam Beatrice, you've heard from the government, and she needs a translator? Yeah. Okay. So you've heard from the government, and he has shared his experiences. As a frontline community health worker, for that length of time which you've been working and serving your population, would also want to hear from you firsthand. What has your day-to-day activities on the front line been like? What are the most significant challenges you have faced? And also, how do you think, the government can improve the services you provide going forward? So it's like a 3-in-1 question. We just want to know how your experiences have been over these 3 decades, and also what are the most significant challenges you've seen in your years of service, and then finally, what do you think is one thing do you think government can do to turn things around? Of course, the systems are not perfect, and so we'll be very, very happy to delve into your wealth of experience.
Murakoze. Nitwa Magnifique Beatrice, ni umujyanama w'ubuzima, naturutse mu karere ka Kicukiro, ibitaro bya Masaka. Nk'uko bari bambajije mu mwanya ubuzima bwanjye mu bujyanama nkora bwa buri munsi.
Sorry, for those who are not getting the Kinyarwanda, she started by introducing herself, her name, and then she comes from one of the districts, one of the 30 districts that we have, and she serves in, she's under one of the district hospitals. I don't know if you've all seen the pyramid. We have district hospital, and then we have health center, and then down to, you come to the health post, and then the community health workers. Yeah. Of course, I didn't talk about the tertiary levels up.
Mu buzima bwanjye bwa buri munsi rero, nk'uko mwabyumvishije, iyo nzindutse mu gitondo cyangwa se iyo mbyutse mu gitondo, mpita nitegura, mbyuka nkora isuku kugira ngo nze kubona uko nakira abantu banjye baje bangana, kuko mbita abakiriya.
Yeah, in the morning, she was asked the question that what is her typical day like. So in the morning, when she wakes up, early in the morning, she begins by cleaning her house, because that's where actually, we didn't mention that community health workers do not have offices or any other place they operate from. They operate from their house, from their homes. Yeah, that's where they receive the patients or clients, if I may. So in the morning, she begins by making sure that her place, her house is very clean, so that, people don't contract maybe other diseases when they come to, so cleaning.
Muri abo bantu mba niteguye kwakira mu gitondo, haba harimo abaje kwivuza, haba harimo abaje kuboneza urubyaro, haba harimo n'abaje kungisha inama bitewe n'ibibazo bafite.
Mostly in the people she receives in her house, she has people who come, patients who come for treatment, malaria, maybe children under 5 who come for treatment for pneumonia and other, we know the IMCI under 5 diseases. Then others also come for family planning, especially the ladies, because community health workers also provide community-based family planning methods. Then others come for advice, they come for advice because, first of all, I didn't talk about the characteristics of community health workers. One of the characteristics to be elected as a community health worker is you must be trustworthy. You must be trustworthy within the community. So people confide in them, so they come to community health workers for advice as well.
Muri abo bantu baza bansanga harimo nk'abo baje kwivuza, hari abaza kwivuza ari bakuru, hari ababyeyi bazana abana babo, mbese izo ngeri zose niko zigenda zigera imbere yanjye. Ari abana ndabavura, ari abantu bakuru ndabavura, kandi nkabavura indwara nemerewe kuvura. Muri izo ndwara abajyanama b'ubuzima tuvura harimo indwara ya malaria, harimo kuvura impiswi, harimo kuvura n'umusonga. Biterwa n'icyo umurwayi aje avuga afite.
Just coming back to the diseases that she normally, as community health workers, are allowed to treat. We have the IMCI, of course. Then there is malaria for both under 5 and adults. They also treat malaria for adults. Then she was saying that their diseases, they have been trained to treat, and whenever they see that a disease cannot be treated or there is any danger sign, then she has to make a transfer to the health facility. Yeah, if she's not allowed to treat a disease that she was not trained for, or when she has seen any danger sign, so she makes the transfer.
Abo bantu bose maje gufasha, yaba ari abaje kwivuza, yaba ari abaje kuboneza urubyaro, yaba ari abaje kugisha inama, iyo barangiye nanjye mpita njya mu mirimo yanjye bwite.
When she's done with the patients that have come, whether for treatment, for advice and everything, then she also finds time to do her own family work, yeah. Because remember, she's a volunteer. So she also has to survive, and she has a family to cater for.
Muri cya gihe nagiye mu mirimo yanjye bwite, kubera ko no gushaka imibereho nabyo ni ngombwa. Kubera ndi umujyanama wo mu mudugudu aho ntuye, abantu bose tuba tuziranye ku buryo baba bafite nimero zanjye, na babandi baje mu gihe nagiye mu mirimo barampamagara nabo nkabasha kubafasha, nta muntu njye nsubiza inyuma.
Yeah, she's saying that the most important thing, first of all, is as a community health worker, you're elected in the village, so you have to be close to the people. So being close to the people means that she's available anytime, whether, like she has said, when she goes to do her own family business or whatever, if it's farming or whatever, but she's still available on the phone. If there is any emergency, then she's still available, despite the fact that she has gone to also do her family activities.
Iyo mvuye muri iyo mirimo yanjye nkagera mu rugo, ubwo nyuma mu masaha y'ikigoroba mfata umwanya wo gusura ba barwayi nagiye nakira, nkareba uko bamerewe, hanyuma nabona hari ikibazo bafite nkabagira inama kubera ko nabagezeho.
And then in the evenings, she also schedules household visits to follow up on the cases that she has treated. So she also does household visits to see the children she has treated, how are they improving and all that. So,
Abo barwayi banjye rero mba nakurikiranye, ngomba kumenya iherezo ryabo. nubwo iyo mirimo yose tugenda tuyikora abajyanama b'ubuzima ntihaburamo imbogamizi, habamo imbogamizi zitandukanye, cyane cyane nko kujya kubasura biragoranye, bisaba kwitanga bihagije, dore ko twebwe abajyanama b'ubuzima turi abakorerabushake. Ubu bifite mu nshingano ukumva uranabikunze, ukumva ni ngombwa ko wagera kuri buri murwayi, ariko ukagira imbogamizi. Ushobora kuva mu kazi unaniwe kandi ari ngombwa kujya gusura wa murwayi, bikagorana. Ushobora kugera mu rugo uvuye mu kazi, abarwayi bagahita baza n'ubundi bagahita bakugeraho, wenda ari bwo ugeze ku meza, bikaba imbogamizi, bikagorana. Hagati aho rero nyine haba harimo ibibazo bigenda bigoranye kandi bikomeye, ariko kubera ko ari umurimo umuntu aba akora kandi awukunze, arabikora nyine bigoranye, ariko akagira gute akabikora.
Yeah, she's touching on some of the challenges that community health workers face, her and her colleagues. One is
njyewe ndebe ngo 90 kubera turabajyana 300.
For instance, in her village, there is 320 households. 320 households. So you can imagine, okay, there is 4 of them, so they have to divide amongst themselves. So it means that she has to cater for at least 90 households. So imagine one of the challenges is means of transport to do the household visits in all those households. Yeah. Another challenge she mentioned is not having a place to work, you know. So in her living room, that's where the patients also come. So sometimes you have visitors and then there is a patient. Sometimes, you know, your family is having dinner and then a patient comes and you have to treat the patient. So that is also another key challenge that they face as community health workers, not having a designated place for working.
Muri iyo mirimo yose dukora, nkuko nahoze mbabwira ko harimo imbogamizi nyinshi cyane. Abo bantu uko bagenda baza, yaba ari umwana yaba ari umukuru, bisaba kumwandika, bisaba gufata igitabo hanyuma nkandika amakuru y'ibyo namukoreye, kuko buri kwezi mba nzatanga raporo ya bya bikorwa nakoze.
Another key challenge is the paper-based. I think as one of the solutions, I will come back to that later in the innovations. Yeah, but currently there is a challenge of, you know, I told you that they have now like 16 service packages. So that means 16 registers, which are like this size. So you have to fill in one register and another one, and then you also have to compile the report at the end of the day, at the end of the week, at the end of the month. So it's like double work. So writing in the paper-based is taking up a lot of the time, more than even the time that they spend on treating, catering for the patients. Yeah. So it's also another big challenge.
Abo bantu bacu rero mu buryo bwo kubafasha igihe cyose bitewe n'uburyo tuba tubanye muri bwa buzima busanzwe bwa buri munsi. Abaturage bifuza cyane guhura n'umujyanama kenshi. Kuba rero bifuza cyane guhura nawe kenshi, no muri cya gihe uri mu murimo, no muri cya gihe udahari, no muri cya gihe wagiye gusenga, nabyo bikaba imbogamizi.
Yeah, she's saying that because the community trusts them very much. So any case, any slight case, if the people want to go to them, or maybe they want the community health workers to come to them. So it's because of the trust that they have for the people. So sometimes you find that it leaves less time for you and your family, as a community health worker.
nta mwanya n'umwe cyangwa se na muto umujyanama atakaza atari mu mirimo irebana n'ubujyanama igihe cyose. Ni ukuvuga umunsi wose uko ukangutse, uko urimo ugenda, yaba ari mu nzira, waba uri mu rugo, waba uri mu rusengero, waba uri mu nama, uba ukora imirimo y'ubujyanama kubera ko ari wo murimo n'ubundi ubusanzwe ukora.
Okay, thank you so much, Beatrice. So we have all heard from her very passionately how she has chronicled the kind of work she does. You can see, so the importance of community health workers cannot be overemphasized. Just beyond working in communities that are very difficult, they work in hard to reach areas, places where ordinarily no one would want to walk. You know, they have to cross the rivers, they work in mountainous areas, sometimes security risk or prone areas, you know. And so, given all this, you know, one gentleman in the audience, you know, stood up this morning and said, what is a fair compensation? What is a fair compensation for these people? I take that to be a rhetoric question. So, and he also gave a brief background how, you know, for example, in Kenya, efforts that started almost 2 decades ago, you know, it translated into now community health volunteers, as they are called, now receiving stipends. But these stipends, are they sustainable? And is it even adequate? And when you talk about even these stipends, how much is the stipend? They said $39. So when you do a rough math, that's about maybe $1.5 per day. What can that even buy you? So, Dorothy, that brings us to your desk. Given this background, okay, so what other innovative financing mechanisms can government leverage to increase the fiscal space for community health programs in Africa?
Okay, thank you, Dr. Gaia. And as I've said, it's baby step that Kenya has done. We really appreciate that. It's very small from how we are translating it, but they have done a good job. 18 years of people advocating and it converting to something small, it's a commitment. Because we know universal health coverage is political. And without the will of the politicians, it cannot succeed. So I have been in the maternal and child health space, and I would like to say that health is not a standalone. It is it is both a receiver and a determinant of the socioeconomic landscape. And I'd like to just share some incidences that I had. You see, from the presentations that we had from Dennis Kanti in the morning, we saw that the maternal mortality, we are not likely to hit the SDGs target in 2030 for the maternal mortality. We can't achieve the 70. And I would like to share an example of 2 incidences when I've audited maternal deaths that really stand out for me. One is a woman who was living 15 kilometers away from the health facility. This woman, we were organizing focus group discussions, or Group NC, as popularly known, in the rural areas in one of the subnational governments in Kenya. And she had all the information. She attended antenatal clinic, but her due date came when she was closed, when it was rain season. It came at night as usual, and there was no one to provide transport. No motorcycle available, no taxi that would take her to the hospital. The hospital was 15 kilometers away. The only solution that was there was a woman to walk and get support from the husband. At a point, she could not walk any further. So the husband had to carry her on the back. They had to walk It took them 2 hours to the main road. Then they got a taxi. It was at night. By the time she was getting to the hospital, she was pronounced dead. The husband, fully drenched, the clothes of the husband, by the time we were doing the verbal autopsy, they were like really drenched into blood. We lost that client to postpartum hemorrhage. But why? Not just because blood was not available or the service providers were not available to provide the service, but because of the transport network could not function for us. The access to the health services was not available. I'll give another case that still stands out to me to date. Another client, she was illiterate, a mother of 8, 9th pregnancy, and she did not attend any antenatal clinic. She was living in a patriarchal society in Kenya, one of the subnational governments that I have supported. She had delivered 8 children at home. And those were successful deliveries. The 9th delivery didn't go the way. She developed postpartum hemorrhage or bleeding after delivery, and the husband denied her permission to go to the hospital. She bled to death. Another verbal autopsy because of the nature of our patriarchal society. So as we talk about community health workers, I would like us to see health as both a receiver to failed systems generally, and also as a determinant of the way our socioeconomic landscape is shaped. And having said that, I would like to highlight health cannot function alone because we already have overwhelming evidence. For example, any single additional year you take a woman to school, it reduces the risk of the woman dying during the child mortality. It reduces from between 5 to 10. That is quite significant because we are working towards that direction. Number 2, if you look at transport, for the women who live in the rural areas, the distance is already a barrier to access of health services. So these women are 3 times at a risk of losing their lives because of the distance. If you look at employment and the economy, any time that we are experiencing hard economic times, we also get budget cuts from our department. If there's unemployment rate, it means people won't be in a position to contribute to the social health insurance fund. And I looked at agriculture so that you can see we cannot operate in a vacuum. And you look at agriculture, we are experiencing very high stunting rates as a continent. And you know, the first 1,000 days in the child of a life, they are very important. And a child who experiences stunting, in future, their income is reduced by 20%. So it means you will be having children who cannot compete with the world market. So agriculture, if they fail to provide us food, we are going to experience stunting. And you know, if they give us that food and we prevent that stunting, then there's a return on investment, very high one, that is even more than our community strategy of 1 to 16. That is economic return for investing in nutrition and averting stunting. So what am I trying to say? I'm trying to say, let's look at health and look at how we can supplement. But do we have problems as a continent? Yes. One of the most, now that it is an economic forum, I would like to say we have very young population as a continent. 40% of our population is below 40 years as a continent. And we know for us to spur economic growth, there are some things that are very important, like demographic dividend. We can only spur economic growth through demographic dividend if majority of the population is between 15 to 60 to below 65, because those are the people who will be in the job market. We have to increase our child survival, which is not doing well, and also work on our family planning. I know Dennis presented, and he already showed us there's no money, and economics is study of scarce resources. So we need to look at how to leverage even before we become innovative. between 30 to 40% of our budget goes to wastage because of inefficiencies. So we can't run away from increasing efficiency in our healthcare systems. That is what really can't stop. But I'd like to highlight one of the government supporting us, Financing Alliance for Health. Okay, we have a catalytic mechanism where we are, as AfHEA, piloting, providing a seed fund to one of the subnational governments, that is Makueni County in Kenya. And the county government or the devolved subnational government is also funding. But you see now this funding from our Public Finance Management Act, this money, the health space, we are not the specialist in gender, so we can't host that fund. We are not specialists in business enterprise, so we cannot train them on income generating activities. So we are unlocking more funding, or we have legislated, the county has legislated policies that would allow the line departments, for example, gender to match or to provide the community health workers with some funding in terms of a grant and a loan to run incomes. And I would say, funny enough, as we continue with this conversation, our community health workers do not even have insurance covers. So that is something that we are thinking critically, how the governments would support through any innovative financing mechanisms to cover the people who cover other people. Yeah, and as Dennis highlighted in the morning, they have showed us for us. We need also to show up for them. I think I'm very passionate about efficiencies because I know we will never get enough resources to support. And I think digitalization is a game changer. And I like to highlight that digitalization, not only for community health, but digitalization and automation of the way we do collect funds, not only in the Department of Health, but across the departments, because it increases accountability and transparency. And I will give a case example of this subnational government that have been supporting through AfHEA for the last few years, where we have we have automated our health systems, and within a year, we have gotten an increase of $20 million in excess of our own source revenue. So I think there is hope, a lot of hope, but my take home would be, let's increase efficiencies as we also explore to other innovative financing mechanisms. But we should know if we fail to live our goals, because the sustainable goals are there, development goals are there, but we are not living them. We live in comfort of our systems. So we're already in the comfort of our systems. We need to up our game to raise to the vision of our goals. Thank you.
Thank you so much, Dorothy. That's very insightful. Those stories were actually very touching, by the way. So when you see these statistics, most of the time, they say these statistics are not just numbers. They are people's wives, they are people's sisters, somebody's mother somewhere. Yeah, it only goes to show that how much we still need to do. But what struck a chord for me was, when you said, a health is not an isolated entity or a standalone entity. So, but I mean, before I come to you very quickly, I want Dennis from the Ministry of Health to also maybe perhaps, just quickly share what, one or two ideas of, innovations that perhaps we can leverage in Rwanda, in the case of Rwanda, and even just beyond innovations, they have to be sustainable. So we will be happy to hear from you if you have anything that have started, or there are any ideas in the pipeline or that other countries can learn from.
Yeah, thank you. Some of the innovations, the sustainable financing innovations we have, one of them is the performance-based financing mechanism, which is the remuneration. We say community health workers are volunteers, but they get a small, it's a pay for performance. It's performance-based financing, which they get on a quarterly basis. So this fund for the performance-based financing is all close to 90%, or if not 90, over 90%, is donor funded. It's Global Fund, it's World Bank, it's the Belgian Technical Cooperation, Enabel, it's, you know, it's donor, it's external financing. So this performance-based financing, which is how the government of Rwanda came up with a sustainable mechanism whereby community health workers are all in cooperatives, doing income generating activities. So in the beginning, for about 3 to 4 years, the community-based the community health workers were getting 30% individually. It's their money, they have worked for it. But then for investment, so 30% was going to them for their performance, and then 70% was being invested in the cooperatives to act as seed capital. Yeah, so after 3 to 4 years, the cooperatives had accumulated enough capital, and then all the 100% of the performance-based financing goes now to the community health workers. Yeah, so community health, the cooperatives, we have around 520 cooperatives, because each cooperative is linked with the health center, which the catchment area where the community health workers serve. So they are at levels. There is green, there is yellow, there is red. So the performance of the cooperatives it varies. You know, these are people who are not, they are not literate, and they don't have any financial management skills. They don't have business management skills. So you find that some of the businesses are not doing well, but some others are doing well. So the cooperatives, they all have net worth, all the 520 in the country, they have a net worth of about close to $13 million, and they generate, annually, they generate close to maybe around 500,000 US dollars. So, but with increased support, technical support, these cooperatives can go even beyond in sustaining the community health workers. So the income, the profits, they are doing various income generating activities, of course, depending on which are conducive in the areas where they live. Farming activities, off-farm activities, like her cooperative, they do, because it's within the city of Kigali, they cannot do any farming activities, so they invested they invest in land, buy and resell at a profit. Real estate houses, you buy and resell at a profit. So they are doing different activities, but you find that these cooperatives have managed to at least keep them motivated. And then another innovation is we have started enrolling. We have a savings and credit scheme for the entire health sector. The nurses, doctors, everybody who is interested, even the ministry level, all of us. So it gives, you can access loans at a very small rate. So within that circle, we are enrolling the community health workers. All of them are going to be part of this savings scheme. So this means that no community health worker can lack maybe health insurance when it's time to pay for. No community health worker can lack school fees or materials for their children, because they are supposed to live in an exemplary life. You know, you're talking about nutrition, you're talking about reduction of stunting, then you don't even have milk or eggs or what, and your child, you as a community health worker, is maybe stunted, or so they have to be exemplary. So that means that they can be able to access income, small credit to at this savings scheme. Then, of course, there is other initiatives like digitization for cost effectiveness. The paper-based, the government of Rwanda spends over $300,000 annually to procure the registers. So that money can be put to other purposes when we have the digitization in place. We have already developed the community health information system, which is already operational and being piloted. Then, yeah, maybe those are some of the sustainable initiatives that we have in Rwanda.
Okay, that's incredible. Very insightful. I know a lot of people will be itching to deep dive or ask questions around these innovations you've mentioned. But very quickly, let's just shift gear to another issue. So, Dorothy talked about the issues around sustainability and how health systems could not stand alone. And hitherto, there's been conversations also, not just around innovations, but integrating the community health program into the wider health system. So, Amy, in Senegal, we just want to hear from you. So, how are community health workers integrated into your national health system? Okay, just for the purpose of sustainability, we just want to hear from you. Can you just share with the audience briefly?
C'est bon. Si, c'est bon, j'ai compris. Merci beaucoup. Tout d'abord, je remercie le charmant public qui ont fait le déplacement pour suivre ce panel. Merci beaucoup. Pour dire que par rapport à l'intégration de la santé communautaire au niveau du Sénégal, dire que le Sénégal a une expérience en matière de santé communautaire qui date de plus de 60 ans, qui a aussi motivé même la participation, même je dirais la contribution du Sénégal dans la conférence de Alma-Ata. Dire que, mais le Sénégal s'est doté d'une politique de santé communautaire qu'en 2013 pour avoir un document de référence en matière de santé communautaire. Et ce document doit être opérationnalisé par un plan stratégique qui est quinquennal. Donc, depuis 2014, tous les 5 ans, le Sénégal a une stratégie nationale de santé communautaire pour décliner les grandes lignes. Aussi dire toujours par rapport à l'intégration de la santé communautaire dans le système intégral. Au Sénégal, on a un système qui est pyramidal avec 3 différents niveaux, mais le niveau périphérie intègre le niveau communautaire. Si je dis niveau communautaire, c'est là où travaillent les acteurs communautaires. Et si je dis acteurs communautaires, le terme que les autres pays africains utilisaient, c'est des agents de santé communautaire. Nous, au Sénégal, on a plusieurs catégories et plusieurs types. Donc, nous, on parle d'acteurs communautaires qu'on a eu aussi à sérier, catégoriser avec un paquet de services bien défini. Donc, tout acteur communautaire a son paquet de services qui a été bien défini en matière de santé communautaire au niveau du pays. Toujours aussi, ces acteurs communautaires, comme je l'ai dit, travaillent dans des entités qui sont appelées cases de santé des fois ou sites communautaires. Donc, ils sont assimilés à de petites structures de santé et ils sont cartographiés. Les acteurs communautaires au niveau du Sénégal ne sont pas laissés comme ça. Chaque acteur communautaire a un prestataire qui est le mentor, je peux dire. C'est à lui qui rend compte. Et il y a aussi des outils de gestion, par exemple les registres, les carnets pour les acteurs communautaires qui ont été confectionnés par le ministère de la Santé. Et même les données que ces acteurs communautaires mènent, c'est-à-dire les visites à domicile intégrées, que ce soit les références, que ce soit les actes pour la prise en charge des maladies
par exemple, qui ne sont pas graves, tout ce que les acteurs communautaires font toute la journée, ils le notifient dans des registres, dans des cahiers, et chaque mois, ils produisent un rapport qui est validé par le prestataire, et ça intègre aussi le DHSI2 qui est l'entrepôt national pour les données. Donc vous voyez, donc toujours pour dire que les acteurs communautaires font partie intégrante du système de santé au Sénégal. Toujours aussi, par rapport à la reconnaissance même, il y a une cartographie qui est menée chaque année, qui est renouvelée pour voir quel acteur est où. Il y a aussi, ils confectionnent des badges d'identification pour ces acteurs communautaires. Et mieux, les acteurs communautaires sont organisés en réseau. Ils sont reconnus par le ministère de la Santé parce que nous, on a des districts. Pour chaque district, il y a un réseau qui regroupe l'ensemble des acteurs communautaires. Pour chaque région aussi, c'est la même chose. Le Sénégal a 14 régions médicales et il y a un réseau qui est là, qui est national. Et les acteurs communautaires participent à des réflexions. Même dans ce genre de conférences, des fois, on a le réseau des acteurs communautaires pour dire que le Sénégal travaille comme ça, pour intégrer les acteurs communautaires, les formaliser, ils font partie intégrante du système de santé. Donc, on n'a pas deux systèmes, on n'a pas un système de santé parallèle en matière de santé communautaire. Ça intègre naturellement le système de santé du Sénégal.
Merci, merci. Enchanté. So, Parfait, do you want to please just summarize what she said? I mean, maybe everyone didn't get the translation.
Thank you very much, Madame Baquet. So I just want to summarize what she said. So she said that she confirmed that the community health workers are part of the national health system, and this is evidenced by the current existing policy document, either the strategic plan and also the policy, but that's a regulation that are in place in the country. They do have 7 types of community health workers, and there is a specific service package for designed for each type of community health workers. And these community health workers are based on to the health huts. And this is the smallest health entity, decentralized health entity at the community, and they are being supervised by health posts. And they have been doing the mapping of the old community health workers in the country, and as part of the current information system existing in the Ministry of Health. And this mapping is geo-referenced to know who is located where and what type of service they are doing, and type of the community health workers, but also all the coordinates around his or her location. And this process of doing the mapping is conducted every year. And Senegal has 14 regions. And this 14 region, they do also have a district up to the lower level. And these community workers are part of all the policy forums, policy dialogue forums, and also decision-making process from the lower level, because they do have their representative. So that's what she tried to highlight it, and ensuring that community workers, they are part of the national health system, including also the service delivery. They are doing a very good job in Senegal, and as part of the ministry mandate and overall policy targets. So thank you so much.
Yeah, thank you, Dr. Parfait. Thank you for that very succinct delivery. So I think at this point, what we want to do is to open up the floor so that the audience can chip in. We'll be very happy to hear your feedbacks, your comments, questions directed to the panelists, and then, yeah, we can exchange ideas and rub minds. Thank you. So happy to open the floor.
Thank you very much. My name is Abaka Kurfi. I work with the National Health Insurance Authority in Nigeria, where I head the Planning, Research and Statistics Department. My first question is to the lady, the community health worker from Rwanda. She said one of her major challenges was lacking a place to work and a designated place to work. And I want to ask, should we encourage community health workers to have a designated place to work? Because then we are making that place a hospital. The idea behind a community is that she works within the community. So your home, the homes of the patients is your own designated place to work. So I think what we need to do here is to inform them, orient them to understand that their own laboratory per se is the community. That's where they will get that's where their services are most needed. Then the second question is to the lady from Kenya around the issue of efficiency. Do we have like an understanding or a deep dive on really what are these drivers of the efficiency loss that you mentioned? Because if you are saying 30 to 40% of resources are lost as a result of inefficiencies, where along the healthcare value chain are these inefficiencies happening? If you can shed light, we really appreciate. Thank you very much.
Bonjour, c'est Madame Diallo Assitoufal, je suis économiste de la santé. Je suis au niveau du ministère de la Santé du Sénégal. J'avais une contribution et une question. Je vais commencer par la contribution. Je pense que pour les soins de santé primaire, on a deux défis majeurs. Le premier défi, c'est lié à la gestion des déterminants de la santé. Je pense que tout de suite, avec l'intervention de la dame venant du Kenya, elle a parlé de la gestion des déterminants en prenant en compte l'accessibilité géographique. Et pour cela, je pense qu'il faudra développer une approche multisectorielle. C'est la raison pour laquelle, au niveau du Sénégal, au niveau du ministère de la Santé, nous sommes en train de développer, d'élaborer des cahiers de charges des différents ministères sectoriels. Par exemple, pour le ministère des Transports, pour l'accessibilité géographique aux infrastructures sanitaires. Pour le ministère de l'Environnement, par rapport à la gestion, la gestion de la pollution de l'air pour les maladies liées à cela, mais également le ministère de l'eau et de l'assainissement par rapport à l'accès à l'eau potable, mais également tout ce qui est lié à l'assainissement pour lutter contre les maladies hydriques et diarrhéiques. L'autre défi, c'est le financement des soins de santé primaire, où là-bas, on a le paiement direct des ménages qui est assez fort, mais également la dépendance au financement extérieur. Excusez-moi. Et pour cela, je pense qu'il faudra mobiliser plus de ressources passant par le budget de l'État. Et pour cela, je pense qu'il faudra un argumentaire basé sur des évidences pour mobiliser plus de ressources au niveau de l'État. L'autre aspect également, c'est la contribution des collectivités territoriales au financement de la santé, surtout au niveau périphérique, passant par les soins de santé primaire, et que les collectivités territoriales travaillent en étroite collaboration avec les structures à la base, et ils peuvent mobiliser plus de ressources, passant également par la coopération décentralisée, mais également la fiscalité locale, pour mobiliser. Pour le secteur privé aussi, le secteur privé au niveau du secteur privé, on peut exploiter beaucoup de niches pour la mobilisation des ressources, passant par la responsabilité sociétale de l'entreprise, la RSE, mais également le partenariat public-privé. Toutes ces niches, la synergie de l'intervention, de ces différentes interventions, vont nous permettre de mobiliser plus de ressources pour les soins de santé primaire. Et dans ce cas, nous allons alléger le fardeau lié au paiement des ménages, mais également faire face à la dépendance extérieure. Pour cela, la question que je vais poser, c'est par rapport aux stratégies développées par les différents pays ici présents dans le cadre de la mobilisation des ressources domestiques. Quelles sont les stratégies que vous êtes en train de développer pour mobiliser plus de ressources pour faire face à la dépendance du financement extérieur, surtout dans ce contexte de rareté de ressources, mais également du retrait des bailleurs tels que l'USAID. Merci.
For those who didn't get this, I'm sure the translation might not be working uniformly across. Parfait, can you help us? Did you catch what she said, or any other person who can translate? Just summarize.
Ok, c'était juste la question Sénégal. Il y avait une question et une contribution. Oh. Okay, thank you. Okay, thank you so much. Sorry. The intervention was one question and one contribution. The contribution was around the social determinant of health and the financing the primary health care under the whole consideration of the social determinant of health and what Senegal is doing. They are doing a multi-sectoral consideration toward the financing primary health care, because as Dorothy mentioned, so social determinant of health has so more say on health financing and mainly at primary health care. So for one practical thing that Senegal has done, it was to develop for each ministry like a kind of what to do, what they have to do in their ministry as a way to address primary health care issues, henceforth also its financing broadly. So she went on giving some different examples from different sectors and how they are related to primary health care and how once financing working there, then we can reduce the funding directly, or we can improve the outcome of the population. So that was the contribution. The question was around asking, she had that there are so many things that a country are doing to mobilize domestic resources. And especially in this moment of decline of resources, or going some partner getting out financing health, what are practical things that countries are doing here to ensure that we are covering the gap? Thank you.
Thank you so much, Pascal. So I think let's respond to the questions and the contributions. For the final part of your remark, which you asked, perhaps we might want to open it to the floor to other, people from other parts of Africa, participants from other parts of Africa, to hear their experiences. I think the gentleman from Rwanda has been exhaustive, and also the Kenyan participants. So if there are any persons in the room who want to make these contributions, we'll be very happy to hear your experiences and ideas. So, but without much ado, let's respond to, let the community health worker respond to the question, and then we'll take it to Dorothy. Thank you.
murakoze mwari mubajije uburyo abarwayi tubakira, nkanjye nk'umujyanama w'ubuzima mfite icyumba nakiriramo abarwayi cyangwa se abantu bose baje bangana, abaje kwivuza, abaje kungisha inama, mfite icyumba mbakiriramo kitari inzu mbamo, nakibikamo n'imiti, ibintu byose birebana n'imirimo nkora y'ubuzima nyibika muri icyo cyumba nubatse, annex ku ruhande.
Yeah, from the question you asked, that if community health workers are having a designated place, the designated place is for receiving the patients in your house, in your home, because that's where they do their work. But they also do outreaches, they do household visits, they do, yeah. So she was saying that it's more convenient to have a designated room in the house which is not connected to your house. You know, you have your family is in the living room, and then you receive a patient. You know, it's sometimes the patients need their own privacy. They need, so that's why she was suggesting that one of to have a designated room within the house, yeah. And it's also for security, because they have storage box where you keep all the medicines and everything. So sometimes you can have stubborn children, they go and play with the medicine. So it's better to have that room which you can lock, and you know that it's accessed by you and the patients. That was her suggestion, yeah. But as an innovation in Rwanda, we have some cases whereby they do communal work for their community health workers. Some contribute, they bring iron sheets, others they bring bricks, others they bring, and then they construct just one room for the community health worker to receive the patients. Yeah, that was.
Ask her, is that all? Her comment? Has she exhausted her question? Was there any other question? Okay.
Yeah.
So
Yeah,
Dorothy.
I want to ask. Okay, sorry. Can I?
Yeah, go ahead, Dorothy. Go ahead. Okay,
Yeah,
okay, you want to respond?
Yeah. Okay.
Ok, merci. Je m'appelle Georges Koné. Je suis conseiller technique en financement de la santé pour Mousso Health. Je remercie les participants à ce panel. Je voudrais vraiment partager le modèle de Mousso. En fait, Mousso a un modèle de santé communautaire différent de ce qui a été présenté au Rwanda et au Kenya. Le modèle de Mousso, c'est un modèle appelé proactivité de l'agent de santé communautaire. L'agent de santé communautaire, il est recruté dans la communauté, il est formé pendant 36 jours, pratiquement 1 mois et demi, il est professionnalisé. Ensuite, il est payé au SMIC. Au Mali, Mousso a des agents de santé communautaire payés à peu près à 40 000 francs CFA, et en Côte d'Ivoire, à 60 000 francs CFA, à peu près le SMIC. Ensuite, il y a des formations de routine pour assurer la qualité des soins offerts par l'agent de santé communautaire. Il fait les soins préventifs, il fait aussi les soins curatifs pour le palliatif simple, IRA simple et aussi le PF avec comprimé. Et l'agent de santé communautaire est digitalisé. Il a un téléphone qui suit tout le paragramme d'évaluation des enfants ou des mamans et qui lui fait des rappels, qui lui donne des consignes. S'il n'arrive pas à prendre soin du patient visité à domicile, avec la tablette, il y a la possibilité, à travers le ticking, à faire une référence automatiquement au niveau du centre de santé, avec la tablette qui vérifie aussi sa prise de décision de l'ASC. Après cette formation et cette professionnalisation de l'ASC, Mousso a un modèle qui est en train d'être implémenté au Mali et aussi en Côte d'Ivoire, on est en train de le voir au niveau de la Zambie, qui est le superviseur dédié. C'est un nouveau acteur qui s'occupe que de l'ASC. On a un superviseur dédié, c'est une personne qui a soit une licence, qui n'est pas forcément médicale, qui s'occupe que de l'ASC, qui a une tablette, qui suit tous les actes de l'ASC. Et le superviseur dédié, chaque superviseur dédié a au moins 10 ASC sous sa coupole qui doit suivre et faire les mouvements. C'est lui qui fait le relais entre le centre de santé et l'ASC. L'ASC est dans le village en train de faire sa communauté. Donc le superviseur dédié est aussi payé à peu près à 150 000 francs, à peu près, bon, ça fait à peu près $300. Et le superviseur dédié est directement en contact avec l'IDE et l'infirmier au niveau du chef de poste. Donc tout ce modèle-là proactif que Mousso met en place, il coûte à peine, lorsqu'on essaie de l'évaluer, le coût financier, à peine $4 par personne servie en Côte d'Ivoire en moyenne et à peu près $3 au Mali. et le coût de formation des NAIC équipés et quittent. Les AIC n'ont pas de moyens de déplacement, ils ont tout, ils sont dans le village. C'est le superviseur dédié qui a une moto qu'on offre, qui permet de faire la transaction, c'est lui qui fournit l'ASC en kit. Et même la gestion du médicament de kit de l'ASC, il y a une application mobile que nous avons développée qui permet de suivre ça. Chaque comprimé dispensé par l'ASC doit être suivi d'une évaluation. Et on suit son stock et le superviseur dédié à cette capacité pour suivre ça. Donc ça rassure la qualité de la prestation de l'ASC et ça rassure vraiment la fourniture de médicaments. Il y a très peu de dispensation. Avec ce modèle, au Mali, le Mousso a été l'une des organisations qui a pu, en cas de crise, dans la zone de Bankas, où il y a les terroristes et tout, à intervenir et à maintenir les indicateurs de santé en matière de couverture, de vaccination, de nutrition. C'est vrai que la situation sécuritaire a fait qu'on a eu à perdre l'année passée un ASC qui a sauté sur une mine, mais pour dire comment le fait de professionnaliser les ASC, l'engagement qu'ils ont et la réduction des indicateurs de santé qu'ils peuvent faire. Donc je reviens au coût, comme je le disais au Mali, à $3 par personne servie, c'est supportable. Et le coût de formation, de mise en œuvre et tout, le training et tout, ça fait à peu près $2000 par année. Training, formation et mise en œuvre, équipement en médicaments. Sur les $2000, à peu près le médicament prend plus de 50% du coût de l'ASC. Donc c'est un modèle que nous envisageons, que nous conseillons au niveau des différents pays, au niveau des bailleurs. J'ai une présentation mercredi à 14h à la salle D4. Je vous invite à venir voir réellement les résultats de ce modèle pour CCM et le coût dans un district sanitaire en Côte d'Ivoire. Vous avez aussi la possibilité de voir sur le site web www.moussohealth.org où vous voyez ce modèle pro CCM bien détaillé et fait. Je m'arrête au niveau communautaire pour Mousso et ceux qui sont intéressés, je vous invite. Merci beaucoup.
Thank you so much. Parfait or Pascal, if you could just summarize that very quickly. We take the response from Dorothy. Unfortunately, we'll have to round up this panel session because we are running very short of time. We will still have opportunities to engage. There is a breakout session that's coming up this afternoon, and so there's going to be lots of avenues or platforms for people to bring up this conversation. So, but we would have to round up this. So, please, very quickly, Pascal, just translate what the gentleman has said, and then let Dorothy give her response.
Okay, let me start by the last one because it's the most important. He has seized the opportunity to invite participants for the session on Wednesday, 2 p.m., AD4. So to really understand very well the tool that he was explaining that resulted in increasing efficiency in different aspects of community health workers where he just only presented, but the tool can be used at the district level, district hospital, and other layers of health system delivery. So what he was just saying, what Musso is trying to do is to do so much advocacy to professionalize and institutionalize the community health workers in different countries, including Mali, Cote d'Ivoire, and very recently in Zambia. So this, which led to a kind of an initiative of $60 pour... Okay, so this is around $100 per month in Cote d'Ivoire and something around $80 per month for community health workers, which is very good, very congratulations. So he was just trying to contribute, showing that what we are saying here is not only like that they are somewhere where there are concrete examples of how community health workers have been institutionalizing. Thank you so much.
Thank you so much, Pascal. Dorothy, please, fire.
Yeah, thank you for the question. And I would like to say we are looking at both efficiency and effectiveness. And when I look at, for example, In Kenya, we recently digitalized our community health. When we were digitalizing, Kenyans don't go report me. We went full scale, full scale. Now, after going full scale, you know what it means for you to correct the mess if the system doesn't work. You move from version to another one to update. In terms of, the system is extremely expensive because of decisions that we made that we never thought through. Number two, if you look at our health products and technologies, we still have some of the governments that are still doing push system instead of pulling the products that they require. So, and I will give an example of some of our kits that we received from the national government, where a CHP has a CHP has a kit. They test sugars. The sugars are high. You refer to the health facilities for management. The hospital cannot manage because they do not have a glucometer. So the doctor now calls the CHP to come with a kit for them to. I mean, some things are they are very funny. You expect you as a leader to think very differently. I like also to highlight another ridiculous one. When we were doing a policy somewhere with Dennis, and then we presented the data to the county, to the leadership. Then we told them, we can see this location as a population of 600 people, but you already have 6 health facilities there. What are they? What interest do you have? Because now you see the people who are driving. For example, I'm the area member of county assembly. I want a health facility. You go put a health facility, but you're not looking at the broader health system. You would require a nurse to be in that post. You would require medication to be supplied. You would require infrastructure to be improved. You would require to define the referral system for that particular place. But now the politicians would look at, I have brought my people a hospital, but not look at the broader system. So when they go on leave, what usually happens, because 80% of the health facilities in Kenya, they are primary healthcare facilities, we close the hospital. So isn't it a waste? So there are so many things. If you look at our healthcare systems and ask ourselves very genuinely, we can do a lot of cost savings. And you know, once you put up the facility, you can't close it. Because if you're a politician, you'll go home. So you better be politically correct at the expense of wasting funds.
Okay. Okay, Dorothy. So thank you very much. These conversations can go on and on and on, but we are coming to the end of this panel conversation. We would want to close. So Dorothy, just before you even drop the mic, I'm sure there will be people, and people can meet you on the corridor and you can continue these conversations. So out of all these things you've said, can you just speak to this audience and tell them one thing that they should just take away, one thing that you want them to take away from this audience, from this conversation you had today. And then after you're done, if you can do that in 30 seconds, that would be great. And then we'll come to the next gentleman next to you.
I'll be very brief, one sentence. If we fail to live our vision, we live at the comfort of our systems.
Thank you so much. Mr. Dennis, any parting words for the audience?
Well, I just want to say that it's, institutionalizing the community health program, making it sustainable and everything, it's doable. It's doable in any country. Yeah, you just need to have the proper, will, the goodwill. Yeah, the goodwill. Otherwise, it's doable, and yeah, it can be implemented anywhere.
Okay, thank you so much. So just before you hand it, so you translate to her. So tell her that we are very privileged to have had someone of her, of her standing, to come talk to us today about her experiences. And so, what her parting words? What would she want the world to hear today as a call to action for community health workers? One thing that she from her years of experience and from engaging with community health, what is that one thing she wants to tell the world so that the media carries it today, and everyone sees it all over the world?
murakoze cyane. Nk'uko twakomeje tuganira, nkomeje gushimira leta yacu y'ubumwe yaduhaye amahugurwa ikaduha ubumenyi. Ubu uyu munsi wa none nkaba ndi umujyanama w'ubuzima, nshobora kuvura umwana, nshobora kuvura umuntu mukuru, nshobora kujya inama ntagiye kubyigira mu ishuri, ari amahugurwa gusa nahawe. Ndabishimira leta y'ubumwe. Ibyifuzo yenda dufite ni uko muri iri terambere turimo twerekezamo muri iki cyerekezo, twifuza nk'abajyanama b'ubuzima ko twashyirwa muri sisiteme y'ikoranabuhanga kugira ngo tujye dukora umurimo wacu neza, dore ko imirimo dusanzwe dukora y'ubujyanama, imirimo yose dukoze turandika. Uko kwandika mu bitabo rero biragorana, natwe twifuza gushyirwa muri sisiteme tugakoresha ikoranabuhanga, tukajya dutanga raporo cyangwa se dukora imirimo yacu mu buryo butworoheye. Ikindi cyifuzo dufite, nk'uko n'ubundi leta yacu y'ubumwe yakomeje iduhugura ikadufasha, n'ubundi dukomeje kuyisaba no kwifuza gukomeza guhugurwa, dore ko guhugura cyangwa se kubwira abantu ari uguhozaho. Ikindi cya gatatu, duhabwa PBF idufasha mu buzima bwacu bwa buri munsi. Mwigeze kumva mvuga ngo mfite inzu mvuriramo cyangwa se nakiramo abantu, iyo anegisi nayikuye muri PBF nahawe. Ubwo mu cyifuzo cyanjye rero, mu izina ry'abajyanama bose b'ubuzima, nifuza ko PBF twahabwaga cyangwa se agahimbazamusyi, nifuza ko kakwiyongera, dore ko n'imirimo turimo tugenda dukora umunsi ku munsi igenda yiyongera. Murakoze cyane.
Yeah, briefly, she was saying, first of all, she's appreciating the government of Rwanda, the leadership of Rwanda, and all the partners for all the support over the years. And she's saying that she's a community health worker who never went to school beyond, but she's like a nurse, she's like a doctor, she can treat patients, so she's grateful for that because of the training she's been getting. So one of the key requests is to continue the capacity building, because capacity building helps them as community health workers. Then two is to increase the PBF, the performance-based financing incentives to increase. She's saying that she told the audience that she managed to build her own room, the other room we were talking about, designated room for receiving patients. Said she constructed it out of the PBF she gets from her indicators, from her performance-based financing incentives. So she built it herself. So she's saying that there is a lot as a community health worker they can do if the incentives are even increased a bit, because also the workload has increased. The workload has increased, so it would be better for them if the incentive is also increased. I think it comes back to the question: how much is enough to remunerate community health workers? Yeah. Then the final request is digitization. We were talking about it. So yeah, to ease the work and yeah, go.
Thank you so much, Madam Beatrice. We are very grateful. And Ami, so yeah, your parting words, if you could just do 1 minute would be great. If you can pack it 1 minute, we'll be very glad. Okay? Did you get that? She needs an interpreter. Parfait. Pascal.
C'est bon.
1 minute, tell her 1 minute.
C'est bon, merci beaucoup. Mais avant de parler, j'aimerais que vous me joigniez à moi pour pour rendre un hommage mérité à la brave dame là qui est avec nous, l'acteur communautaire. Merci beaucoup. Merci. Je vais dire un mot, qui est que le Sénégal maintenant a compris que pour atteindre la couverture sanitaire universelle, il est impératif de trouver un financement, je dis conséquent, mais surtout durable pour la santé communautaire, je dirais même pour les SSP. Et cela veut dire que maintenant on est dans de grands chantiers avec la brave dame qui est devant moi, Dr Tchane, qui est en train de révolutionner le système de santé communautaire en matière de financement de la santé, parce qu'on a commencé avec son équipe qui sont là, la cartographie des investissements en santé communautaire. On va aller aussi à un dossier d'investissement de la santé communautaire. Il y a aussi l'assage stratégique. Vous parlez de performance basée sur les résultats aussi. Elle a mis la santé communautaire dedans. Je pense que c'est quelque chose que je tenais à dire. Et tout cela aussi remercier AfHEA qui nous appuie techniquement et financièrement pour pouvoir atteindre ça. Donc le Sénégal a compris et nous sommes lancés dans de grands chantiers, à savoir la cartographie pilotée par le ministère de la Santé, mais aussi le dossier d'investissement et aussi l'assas stratégique. Donc c'est ces précisions que je voulais faire en remerciant tout le monde. Merci beaucoup.
Merci, merci. Pascal. 1 minute.
Okay. She was just briefly. She was thanking everyone here, but more specifically the community health workers who provide valuable services to population, and also thanking the Ministry of Health and Social Affairs in Senegal through Madame Tiane, who is revolutionizing the health financing and mainly putting the community health services into the package to ensure that there are sustainable financing mechanisms to that. And thanking Financing Alliance for Health for all the technical and financial support, and especially what the organization is doing at community health workers and community health programs, and thanking everyone in the room for all the support that you have provided. Thank you so much.
Thank you so much, Pascal. So it has actually been a very delightful engagement. Everyone can attest to this. I want to specifically thank our panelists for sharing your thoughts, your years of experience. Again, for engaging. With this, we have come to the end of the panel discussion. The conversation does not stop here. We have, I think, 4 more days to go, and so I'm sure we'll be engaging on the corridors, in the pods, on coffee, anywhere. The conversation does not stop, and we'll keep working towards equitable health systems. For me, my parting words I know is that when I started hearing about community health, the first thing I had was that investing in community health is smart investing, okay? And then there's good return on investment when you put money or you channel money towards community health for strengthening health systems. So with that, please, can we put a resounding round of applause for our panelists? Thank you so much. Thank you so much, Madam Ami. Thank you so much, Madam Beatrice. Thank you so much, Mr. Dennis. And Dorothy, we are really grateful. Thank you so much, everyone.
Okay. Come on, guys. Let's give a round of applause to the team here. You can do better than that. Are you guys okay? Should we continue? Okay, you guys are hungry, eh? Okay, so we'll break for lunch. We are going to the Radisson Blu Hotel, which is at, when you entered, Perfect tells me this side, sorry, my sense of direction.
Both ways can get there.
Oh, both ways, okay. Get to the Radisson Blu. Please have your tags for you to access lunch. You'll be given a name tag, I believe, or rather, a voucher, sorry. And then we can convene here at 2 p.m. whereby we'll have one presentation case study from Senegal, and then we'll now have a breakout session. I see your hand up there. Do you want to announce?
If you go right through past Radisson, there'll be directional people helping you to direct, but you're looking for Larder, the restaurant Larder. So go past the reception and then to the left.
Okay, great. See you guys at 2 p.m. Thank you, guys.
Just one announcement for brother and sister Muslim who are here in the room. There are praying rooms around, so you can use them. And we didn't forget you that when we are going to break the fast, we will tell you what next. Thank you. Yes, 20. Hello. Good afternoon. Ok, bon après-midi. Je crois que les francophones sont plus nombreux maintenant dans la salle. Donc, on va parler maintenant en français. Même les présentations vont être en français. Ça va, qui sont d'accord que les présentations soient en français? Oui. Et qui ne sont pas d'accord? Donc, Shivani, now because we are doing democracy, so you are presenting in French because the majority is in French. So, welcome back. I think the lunch was good. And one way to see that the lunch was good is when you see people tired after lunch. So it means that, so we want to do the next session that we talked about different mechanisms that are being implemented in countries, especially where AfHEA is providing technical and financial support. And one of the examples we want to do is to see now the tool that was used and the assessment around community health program financing and how it's being done in Senegal. So we welcome Shivani, our colleague, to present the findings. Thanks.
Thank you, Pascal. So I'm just trying to pull the slides up, and unfortunately the technician is not here. So maybe, all right. Well, thank you everyone for joining us today, and a very good afternoon. I know it's been a long day, so we've had a lot of information thrown at us since the morning, and this is actually the final stretch. So this is last 30 minutes of the presentation, and we'll get some good information, but hopefully we'll be able to decompress in the next session, which is breakout groups. So you can talk to each other, and we'll be able to hear from you rather than us, which is really more important. Today, as Pascal said, I will be talking about the community health financing assessment that we did in Senegal. So one of the things that we've often heard in global health is that countries across the globe do not have sufficient technical capacity. When I say across the global south do not have sufficient technical capacity, and even the fiscal space is limited, as we saw Dennis highlight in the morning, Candy saying the same thing. And so, in an attempt to support governments across sub-Saharan Africa and help them really set the foundations right to sustainably finance community health, we developed the Community Health Financing Assessment Toolkit. I'm going to share with you the insights from the Senegalese context from this assessment, developed by us, the Financing Alliance for Health, and piloted by the Ministry of Health and Social Action who will present with us today. So we saw Madame Baké speak, who is a part of Ministry of Health and Social Action in Senegal, and she was one of the leads in piloting this toolkit and implementing it in the country. So we also had a lot of other national key stakeholders, various international partners, and this exercise was undertaken to evaluate the context of community health in Senegal, the financing opportunities, and explore innovative financing pathways to ensure sustainable financing for community health. And so over the next few minutes, I'll be taking you through these things. So let's first begin with the community health landscape in Senegal and what it looks like. So Senegal is a low and middle income country, we all know that, that has made significant efforts in health financing, yet like other countries in the global south and in sub-Saharan Africa, as Dennis again said in the morning, it faces fiscal constraints that impact investments in health, and they crowd out investments in health. In 2023, we see that government revenue was approximately 21% of the GDP, yet the total health expenditure was only 5%. Health spending per capita was $74, which fell short below the UHC benchmark of 86 per capita, and approximately 60% of the population of Senegal lives in poverty, emphasizing the need for affordable healthcare, especially in remote areas. And as we've heard this a number of times today, we know that health financing in countries like these often remains fragmented with reliance on user fees and donor assistance. So if you see the graph there, which shows the sources of health spending, you'll see that the orange is really high, and that has remained high for so many decades. And there's also heavy external assistance. So the orange part of the graph is user fees, the out-of-pocket spending, which is not paid for, which is paid for by the people themselves. And we also have really heavy external assistance, which is funding coming from donors. But you also have other indicators we've mentioned here, like the maternal mortality ratio and the doctor, nurses, and midwives per capita. So you can have a look at that. Now let's go a little bit more into the community health landscape of Senegal. So Senegal has built a strong foundation for community-based healthcare with policies designed to expand access to rural areas. And we've seen this over the years, starting in 1967, where they established rural health huts, which were set up to provide basic healthcare services. And this came in through Catholic health organizations. Then we have 1970s with launch of community participation projects, where we see communities actually managing health services and generating income themselves through sales of medicines. And then we move on further. We see that in 1989, Senegal adopted its national health policy. In that year, slowly there was a little bit of decentralization. So we see health districts forming. And then in 2012, the Community Health Unit was created within the General Directorate of Health. So this all speaks to the political will of the country. And when you see political will being institutionalized, or you see the symptoms of whether the country has political will, this is how you'd be able to see it. You see that there is a Community Health Unit, which means the country is actually trying to prioritize community health within their health systems, which is extremely critical today. Then we see the National Community Health Policy in 2013, which was officially adopted. And then most recently in 2024, the PHC National Strategic Recovery Plan came into picture. You also see the cadres. So we've also seen this in the morning, and Madam Baké has highlighted this as well. We have 7 CHW cadres in Senegal, 50,000 plus total CHWs deployed, and these cadres work across the board. So we have ASCs, who are general frontline CHWs. We also have others who focus more on maternal health. So we have matrons who focus on maternal health, and pardon my pronunciation, I don't know French. But then we also have others who are more focused on ICCM delivery, service delivery. So we have DSDOMs who focus on malaria, pneumonia, diarrhea management. So there's a lot of different, well, not a lot, 7 cadres who focus on different activities across the board. And they have demonstrated that there is not much duplication across these cadres as well, which is positive. We also see on the left box the National Community Health Strategic Plan. Okay, we don't see it anymore. Sorry, there's some internet issue, so it'll take time to pull up, but let me just voice it over regardless. So the National Community Health Strategic Plan ran from 2020 to 2024, and it had 5 key areas that it focused on, actually 4 key areas. So increasing demand for healthcare services was one, improving service access and quality at the community level. Then we also had strengthening the governance and coordination of the community health programs and better integration of community health data into the health system. Now, these were the 4 key goals of the National Community Health Strategic Plan, which ran from 2020 until 2024, and the next strategy is now being developed. So we'll see it run from this year to the next 5 years as well. Now, I'm gonna look at the technician to just help me with the internet, because it's, I would need to present the slide. Okay, now it's suddenly recovered. It should, sorry, it should be up. Okay, perfect. So now here we see, now moving slowly into, now we've seen the landscape of Senegal and what is happening at the community level, but what is needed? Why are we doing all the things that we're doing? And we've highlighted so many challenges today. So what is it that, why did we really go into Senegal? Why was it important for us to do this assessment that I'm going to discuss? So community health in Senegal, while it has made a lot of progress, but urgently needs more resources and better support. And we've seen this across countries in sub-Saharan Africa. There's high user fees and reliance on external assistance and fragmentation. So this makes it really difficult for them to sustain, for any country in fact, to sustain any kind of initiative over the long term. So to ensure that any initiative is durable and sustainable, it needs to be led by the government, and it needs to have set the foundations right in terms of institutionalizing things, in terms of making things strong at the ground level, so you're able to sustain over the long term and it doesn't disappear when donors disappear. So there has been a growing need for more innovative, contextually relevant financing strategies. And governments actually need visibility on what are the long-term financing pathways. So as Dennis highlighted in that chart today, we saw that the fiscal space is constrained. How do we move away from donor funding and move towards something that's more self-sustainable? How do countries transition to financing their health systems through domestic resources compared to external assistance? And to do all of that, government needs some kind of technical support, is what we've noticed over the past few years. And to give governments that visibility on long-term financing pathways and which are the catalytic investments, which are the options they can choose from to finance their community health systems, we ended up building the toolkit. So, here, to address the financing challenges and a $4.4 billion funding gap for community health in sub-Saharan Africa, AfHEA conceptualized and developed the CHF Assessment Toolkit. Now, this toolkit was ideated during a donor convening, a stakeholder convening, which happened in 2021, and the partners and stakeholders, including the governments, have highlighted the strong and urgent need to address these financing challenges and the $4.4 billion funding gap. And so we conceptualized a toolkit which will be able to help governments easily and simply be able to get that visibility by themselves. So they can self-assess, they can answer questions and get that visibility on what are the investments they can make, what are the bottlenecks within their community health system, and what is the action plan for the next 5 years. So to be able to do that in a simple exercise that uses a tool, we developed this. Now, this toolkit was successfully piloted by the support of and the leadership of Ministry of Health and Social Action in Senegal. And we have Madam Baké who can speak a lot more on that because she led a lot of this exercise. And we also had other key stakeholders. And now the toolkit is launched. December 2024, we launched the toolkit. It is accessed by a number of stakeholders across the globe and 25 plus countries, and we aim to continue to partner with more and more governments and support them through this exercise. Now, AfHEA's toolkit, as I said, was piloted in a workshop and that happened last year. There were 30 plus stakeholders involved to assess community health in Senegal. And we had a number of partners who were involved in this exercise, and including AMREF, we have Plan International, UNICEF, of course, the government of Senegal. We also have World Health Organization and a number of other key stakeholders who were involved. We received great feedback as well. So we saw that well, let me get the numbers right. We saw that more than 64% of the participants rated their experience as good, and 21% said it was excellent. So it really helped them assess the gaps within their community health program. And 50% of the participants found it really useful as well, in fact. Additionally, we have Madam Baké's quote, which says that it actually helped develop the 5-year action plan for community health financing in Senegal. Now let's actually dive in quickly to the toolkit itself. So what is this? What is it that we have built and what are we trying to do with this? So the toolkit is an evidence-based self-assessment to aid stakeholders in developing innovative and equitable financing strategies for community health. And an interesting aspect to it is that it displays the best practices. So there's a lot of research done, and we have embedded the best practices that will be displayed automatically when you answer certain questions in the toolkit. So when governments come together with stakeholders, they would answer certain questions, and then they would be able to see, based on their context, which are the best practices to follow and what is the action plan. The tool is targeting, obviously, policymakers, funders, implementers. But here it is important, and I would like to highlight that it's not just Ministry of Health. We know that it is just not a single ministerial approach wouldn't work. So because there is a need for strong coordination across ministries to be able to fund community health. We have ministries of finance, ministries of planning, also gender, which Dorothy highlighted today, which is an important aspect to consider. So a lot of ministries coming together, funders coming together, implementing partners, and eventually who will be trying to benefit? It is community health workers from the increased, diversified, and equitable investments in community health. This toolkit works both at subnational and national levels, so it can be customized, and we continue to work towards customizing it for countries. Now, it has two parts. So you'll see this is the first, in the checklist, we have the first toolkit itself, and we have the action planning framework. So the toolkit is divided into 3 parts. There's the context assessment, then there's a revenue raising analysis, and then the innovative financing analysis, which I'll go into the next slide. But here, just to give a gist of what it looks like, you see that there are a few questions on the right. So it is trying to assess the effectiveness of pooling of funds at different levels. So how is the government actually pooling funds at different levels? And you see that for Senegal, for example, it's clicked that funds are centrally managed at the national level and allocation is based on regional needs. Similarly, for fragmentation and coordination, we see that the response was limited coordination and it is mostly at the partner or national level. And similarly, we see other answers. So based on the responses to these questions, you see that on the right, these recommendations on top, which are displayed, they would automatically appear, and then you can also edit them based on the technical advisors who are present in the government inputs. And then you develop the action planning framework. So as I said earlier, the tool has 3 parts. I don't know if it's displaying. Nope. Hi. Okay, so, all right. Anyway, so the toolkit has 3 parts. There's the context assessment, which is section 1. It has 3 sections, 16 components in total, and 66 multiple choice questions. It sounds like a lot, but when you're trying to fill it up, it doesn't, it's not, well, you have different questions across sections. So for the first section 1, which is the context, you would have questions which talk about alignment with local health needs, integration with a broader health system, adequacy of the policy and legal framework for community health, effectiveness of government structures, HRH components, including a gender component, so gender analysis as well for CHWs. Then you have the second section, which is the revenue raising part. So you talk about costing. So how much is the community health program costing? Is the funding that is coming into the community health program sufficient? Do we have enough money to fund the existing community health program? All right, suddenly it's appeared. So I'm going to pull back the slides. All right, so on revenue raising, yes, so this is the first thing that I talked about was context. So you have these 4 components in the context. You have certain multiple choice questions in the context part. Then you have the revenue raising part, where you see costing and sufficiency of funding, diversification, stability, and predictability of funding. So how predictable is the funding which is coming in? So if you have different donors, different funders who are funding the community health program, how predictable do you think it is to your program, how long it is funded for, and other aspects of stability. And then you have effective pooling of funds at different levels. So how are funds pooled? How is the stakeholder coordination looking like? We saw that the 5-year plan in Senegal for community health showed that there was commitment to strengthening governance and coordination. And this aspect can actually help assess those things. So you also assess fragmentation and coordination and barriers to adequate funding. And all of these things are going to be assessed by the government themselves in collaboration with different stakeholders and partners who are involved and the technical advisor. Then we have finally the innovative financing aspect. So it is important to keep in mind what are the financing goals for that community health program. So we cannot be funding anything in a way that's not suitable to the program. We need to find funding which is relevant to the program itself, the health needs, the eligibility of the funding to that specific program. So we look at first the financing goals, then the current innovative financing mechanisms. Has the country used any innovative financing mechanisms already? Is it relying on grants? Is it loans? Which loans? And things like that. And then applicability of mechanisms to the local context. So how applicable is that mechanism to that context? Political and technical feasibility, which is extremely important. So if you anticipate that the government's not going to be, the program is at risk of political instability and has other technical risks, then it would be difficult to really implement any new innovative financing mechanism. Then it would give you a short list of suitable options, and it will show you proposed impact and risks. So what the stakeholders would do is discuss and respond to these questions during the workshop, which is guided by technical advisors, review the key issues and recommendations, and draft an action plan. And this is what the action plan looks like. So it's here you just see the issue, recommendation, improvement activities, what is the priority of that activity, and then the timeline. So how are you going to implement it over the years? Now coming to the actual bit, which is what were the findings from this self-assessment, which is really important. Now, so the self-assessment in Senegal, the context assessment, which is the first section we talked about, surfaced some challenges facing community health service delivery. So while we see that CHW roles and ACS cadres are well defined, but there are still a lot of gaps that need to be addressed. And the first few gaps you see here are data gaps. So a lot of numbers are not known. Now, for example, if you see the ACS to household ratio, how many ACSs are actually delivering to how many households? Is the workload a bit much? Are they well supervised? So these are the ratios, this is the kind of data which is needed to understand workload faced by ACS and whether they're well supervised as well. So all of these factors are extremely important to know. And this was one of the challenges with the CHW service delivery in Senegal. So the recommendation which came out of that workshop was to establish these ratios, find that data, and work towards understanding what the workload and access and supervision looks like. Second is, while CHWs are mentioned in the policy documents, there is no legal framework recognizing them in HRH or planning documents. So while they've been mentioned in a community health strategy, there's no legal framework which actually protects CHWs and the work they do. And so it is important to advocate to define the legal status and collaborate with different departments to include CHWs in these policies. Then let's go to training. So training is not standardized, and there's no clear pathway for how community health workers can grow within their roles. And very importantly, most are female and few hold supervisory roles. So while most of the community health workers are female, there's barely any community health workers which are actually holding supervisory roles, which is extremely important. And so the recommendation which came out of a very comprehensive discussion was to develop a clear framework for career development, regular training sessions, and further to strengthen the capacity at health post level, recruit more community supervisors. This was something that came out of the discussion during the workshop as well. Then they work varied hours, so they're not sustainable. They have few formal contracts, which can actually contribute to burnout, in addition to not knowing what their workload is. And job security is obviously critical. We also know that the compensation, we also found that the compensation from varied sources is not harmonized. So there's different sources which are actually providing compensation to these CHWs. There's fixed salary, in-kind, fee-for-service, so various different sources, not something that's consistent. And so among other recommendations, to advocate to local authorities so that ACS actually have signed contracts describing their rights and responsibilities, and then moving on to consistent compensation. So this was context assessment, and now we come to the revenue raising bit. So some of the barriers in resourcing community health included a need for an investment case for advocacy. Now this is extremely important. So the department recognized the need for better advocacy, stakeholder coordination, which is need for collaborative forums, to ensure long-term funding for a sustainable community health strategy. And one of the big challenges is lack of an investment case for community level can make it difficult to advocate for more resources. So if the Ministry of Health is actually saying we prioritize community health and we want investments in this, they would still have to make a case to the Ministry of Finance asking for why, or why it is a good investment, or those aspects. So making an investment case for anything is extremely important. And at this point, in community level, community health is something that's really critical. There exists a costed operational plan. So while there's costs that are known for the program, there is a need of comprehensive costing and planning tools. So there are no consistent tools which can actually capture the data on what are the costs of the program, how is the revenue actually coming in year on year, and how can you plan it comprehensively. So there is a strong need for comprehensive costing and planning tools that are standardized and support the government in this. There's also no budget line, and we've heard this across countries. Lack of a budget line for community health makes it really difficult and threatens the long-term funding for programs. There's limited data, again, and need for interministerial coordination and advocacy. So these are some of the revenue-raising challenges. So these are foundational aspects which actually threaten how the government is able to raise revenue for community health program. And some of the recommendations that were made to address these include developing a comprehensive investment file. So all of these recommendations do not come from Financing Alliance for Health. It is interesting and most important to note that they are coming from the government themselves. So they are highlighting that they need to develop a comprehensive investment case for community health and incorporate standardized tools to collect data, align it all with their broader plans, so aligning community health plans with their broader objectives and plans, include a budget line, and strengthen advocacy so that the CSSP, which is the community health unit per se, becomes a department in its own right. So that is something that the government has expressed, that it is important to strengthen advocacy so that it becomes a department in its own right. Now I'll have to wait again. Yeah, so maybe I can actually pause here. I see that, everybody's quite tired after lunch. So in case there are any questions or any comments while this is pulled up, I can actually pause. Yes.
Thanks a lot for your presentation and providing a tool. So my question is, are you able to track progress over time and document what has been done? And this is for the purpose of producing an evidence brief at the end. And also too, is the performance, is there an outcome, like a health-related outcome that is tied to the assessment? So maybe there's very good performance, and then we see that the health indicators are going up and things like that.
Okay, yeah, thank you. No, these are really great questions. So the first question on tracking progress over time, that is something we are looking at and we're really keen on doing. So we do want to measure how the country has progressed. Let's say if we do an assessment today, this year, then we again check next year and go forward and see how the country is actually moving forward. And there's other metrics and scorecards which actually we want to embed into the toolkit itself, so countries able to benchmark themselves and see progress over time. So yes, that's something that we are definitely looking at. And the second was around impact on health outcomes. That is not something we've looked at yet, and that's a great point. We should be considering how it is actually, we should be able to track health outcomes as well and see whether this is making an impact, but that's so it's a different conversation altogether, I feel. But yeah, that's a great point, so that's well taken, yeah. All right, we're back. So, yes, coming back to it, and this is the second part of the assessment, which is the revenue raising bit. So what did we find in the revenue raising assessment? the participants highlighted that resources are significantly insufficient for the community health program. So while they know the costs are really high, the revenue, the resources which are coming in are not enough for the program to sustain. And so, and a lot of this assistance is actually coming from external sources. So if you see on the chart on the left, and this does not reflect the amount of funding that each partner, donor, or the national budget is contributing, it's just to reflect who are the people involved. So we have UNICEF, you have other grants from Gavi, World Bank, other voluntary contributors. Blended financing was also something that was highlighted, Global Fund Debt to Health, private provider financing, results-based financing, World Health Organization. So a lot of mix of different funding sources which were highlighted during the exercise. And it also showed that the goals of the financing mix for community health program were these 4. And what the government wants to do is reduce reliance on external aid, 1, increase and more optimized allocation of funding. 3rd is increase domestic financing for community and primary health care, achieving balanced mix of public and private funding. And the key revenue raising issues, we again see there's an urgent need for investment case, the costs are super high, funds are centrally managed with limited coordination. There's a need to understand impact of using innovative funding mechanisms. So this also speaks to your question where you asked what is the impact of different innovative financing mechanisms or whatever assessments we're doing over time. And this also speaks to that question because we would want to first know if, for example, results-based financing has worked in the past in that context, and if not, what can be done to address it, and what are the other areas or approaches we can look at. So it is really important to document the impact of whatever financing mechanism was employed. Then you have limited evidence of joint initiatives, and pooling is ad hoc. So there is a strong need for better and better coordination, joint initiatives, more collaborative forums. All of this is highlighted time and time again. Now let's look at what the government expressed interest towards. So stakeholders have expressed strong interest in new sources of financing community health, which is results-based financing. And stakeholder views on innovative financing mechanism are highlighted here. So what we did was we assessed this mechanism on its eligibility to the local context, applicability, feasibility, whether it's feasible to even have something like this, and impact. And this is all the views of the stakeholders themselves. So they believe that the eligibility for the program, RBF, aligns moderately, and the eligibility of the program for RBF is moderate. There's strong political will, and we see that over the years in Senegal, and we do see that for these innovative financing mechanisms as well. So we've seen that there is definitely political will, but it's important to understand how to institutionalize this will. Applicability of mechanisms to the context. So the mechanism is applicable with certain gaps that need to be addressed. So certain things which have to be taken care of, but it does. The mechanism is applicable to that community health program. Potential for impact is high, is what was stated. So there's significant improvement in preventive and curative services, leading to sustainable boost in community health outcomes. And the risks include financial, political, and implementation risks. So that there are still a lot of risks that need to be taken care of, and that is why it's really important to document and have a risk framework. The average funding size is highlighted on the top left, and a very, very important point here is comprehensive buy-in is needed to implement this mechanism from other ministries and stakeholders. So to be able to successfully implement results-based financing for the community health program in Senegal, it is extremely important to have buy-in from stakeholders across ministries. And so finally, we're coming almost to the end of the presentation, and I see everyone's quite lazy after lunch. But let me get to the lessons learned. So in terms of the lessons learned, oh, great. Yeah, everyone's gotten lazy after lunch, including internet. Okay, let me get to it anyway. So lessons learned from this exercise. What is it that other countries can also learn from this? Advocacy is critical to secure stakeholder buy-in and get more resources. So advocacy is a big part of this whole framework. An investment case is absolutely critical, whether it's at the subnational level or the national level across ministries. So if you want to advocate for funding to Ministry of Finance, whether subnational government wants to advocate for funding to the national government, advocacy is key. So there needs to be buy-in and there needs to be a seat at the table. Need to institutionalize CHWs so they are consistently supported. So that again comes to the same thing, including them in broader HRH planning frameworks, documents, and creating long-term pathways. Balanced financing mix, effective pooling, long-term funding for community health is critical. So balancing financing mix, and that's also a debatable topic. What exactly is a balanced financing mix and how is it relevant to the local context and all of those aspects. The other big thing is better data and standardized tools to fund programs. So to be able to understand how much funding is needed and how the funding would change over time and inform decisions, better data is critical. And the final is stakeholder coordination, which we've highlighted quite a few times now. And now, all right. So coming to the end of this presentation, let me also say this. So in terms of the bottom line for what this toolkit did and why was this important, it is more than just knowledge sharing. So the toolkit, rather than just confirming or reaffirming the challenges that, let's say, Senegal has faced, it is doing a lot more than that. So what is it? How is it helping? It's providing a structured framework and data-backed assessments to refine the financing strategies over the long term. It is bringing together different stakeholders and stirring up a lot of conversation, which is extremely important, especially within the government or across stakeholders. So donors, governments, community representatives, everybody is coming together to talk about these critical issues, and that really helps take things forward. It is also helping identify specific policy and funding gaps. So you're able to clearly see where are the funding gaps within the community health program, which are the specific bottlenecks which need to be addressed. It has shifted conversation from short-term funding to long-term sustainability. So we're talking about long-term financing pathways rather than thinking about what to do next in the next 1 year. What does the program need tomorrow? We're actually talking about what does the program need over 5 years, over 10 years? How can it be sustainable for the broader population? And it has also, of course, influenced the next phase of community health financing in Senegal. So we would like to specifically extend our sincere thanks to the Ministry of Health and Social Action in Senegal for their remarkable leadership and consistent support during this exercise. We also would like to thank our key partners who made this exercise a success, and obviously our Financing Alliance for Health teams. So we have Tapsoba and Dr. Parfait, who had been key for implementing this toolkit as well. And if you'd like to access the toolkit or check out how it looks, what it does, or even collaborate with us and pilot this toolkit in your country and see how we can come together and customize it for your context, please do reach out to us. You can look at the website at Financing Alliance for Health and go to resources and find this, or you can also reach out to us over email. And the next steps include customizing the toolkit, assessing community health in other countries, and sharing lessons widely for cross-country learning. So whatever we did in Senegal, that is now being collated into a case study, which we will be able to publish and share so that other countries could also potentially learn from it. So that is the presentation. Thank you so much.
Thank you, Shivani, for this very good, long, insightful presentation, and very interesting because I can see how the appetite people are following the presentation. So we pass to the next session, which will be question. So question in the audience are welcome.
Thank you very much for the presentation. So when I was checking the stakeholder comments, for example, we talk of the results-based financing. And why we have community health workers is because we want to bridge. If we are to achieve UHC, we want equitability. But from the equitable way, we need to assure that we have quality. And we know that the performance-based financing incentivizes people to report in terms of how many more people have you reached because you're being paid for how many mothers have you, but it may not translate to the quality. So does the tool capture that quality aspect? Because it's the most important. And it also helps us to move if we're thinking of now giving a range of services. And you see, it incentivizes services that can be easily paid for, as opposed to a preventive service, as opposed to this, because one, you cannot automatically really say we're paying on this. So how does the tool capture that so that it can be actually sustainable in the end? Because we need to scale it up. And my second question is, there is the potential, because when the work is being done, it means for governments to take up, we need to first prove that it is effective, not just the cost. And if we are to scale up for it, because the projects cannot be done in every. So you realize we need to document what works and what doesn't work, because if it gets generalized to the country, then the general equilibrium effects don't hold. What does the tool do? Does the tool have that so that we can be able to get the lessons learned so that the scaling up can be better and governments can be able to uptick using the right measures that have been captured? Thanks.
Yeah, thank you so much for that question. So maybe I'll start with the second question first. The toolkit actually is, so it has a lot of different qualitative questions. So the point of the toolkit is to really capture what the government is trying to say and what the stakeholders are trying to say. So inherently, it is made to understand in a tailored way what the local context is looking like. And so it's not as if you just see something displayed which is very general, global best practice. No, you can actually customize it, and your answers to each question are going to be different according to your context. And what we're now trying to do is also customize it further, ask the right questions, and that's extremely important. So asking the right questions based on the context is extremely important. So that's what we're trying to do. On the first bit, I would just take that as a feedback, and I don't have much to say there, but that's something we can consider to improve on the toolkit, and yeah.
Thank you. On the second question, where my colleague was asking, I also, in terms of customization of the tool from one country to another, I think it would be better if it's not there to have maybe a section or to allay AfHEAs of whereby you're using the RBM or the RBF system to remunerate, and it might cause people maybe to even inflate the numbers so that they get more PBF. So to attach a qualitative index so that you're able to track even the improving indicators. For instance, here in Rwanda, how we do it, we track the improvement of the indicators, and then some indicators, the unit cost is either lowered because it's being achieved, and some other indicators are even replaced because they have been achieved. So it would be better to have that, to help with the tracking, so that you get value for money for the incentives that you're giving. Then I just have one observation, whereby you talked about institutionalization of the community health program. It's just an observation I've seen with many country presentations in different platforms and conferences, whereby the volunteers down there at the village level, the community health volunteers, some are given an incentive, a small one, others are not given even any incentive, and then you find that there is a very big, I mean, I don't know if I should say fear, to make them part of the HRH pyramid. Yeah, because it binds them to give them contracts, to give them like a minimum wage, because they are now part of the HRH pyramid. So most countries just decide to leave them there as volunteers, and then what they do, they bring in more advanced cadres at the next level, maybe at the health post level, who are going to be given monthly remuneration and maybe other benefits and what. So you find that those volunteers are not here. Even in Rwanda, we are developing now, it's in the pipeline. The name has been evolving. First, when it began, they were called Certified Community Health, Certified Community Public Health Workers. And then now the name has evolved to community nurses. So those ones will be given a salary, they will be given, yeah. And then, but you find that those ones at the lowest level, at the base, they are doing most of the work, and they are doing, yeah. So it's just an observation which can be, yeah, maybe see how to include them in the.
No, thank you so much for those comments. Yeah, we keep having these conversations within the organization as well, and that's, yeah, thank you for saying that.
Yeah, thank you, Shivani, for your presentation. Let me go in French, okay? Because there are many people in French in the room. En fait, c'est pour dire seulement que nous avons pu utiliser effectivement l'outil. J'ai été l'utilisateur de l'outil. Je suis conseiller technique principal en financement de la santé au niveau de Financing Alliance for Health. Et c'est elle qui a été notre boursière dans le cadre de l'utilisation de l'outil, Madame Baké. C'est vraiment un outil fantastique. Les gens ont vraiment apprécié. Lorsqu'on a utilisé l'outil, les gens ont vraiment apprécié l'outil à hauteur de 80 à 90%. Et l'outil nous a vraiment permis d'identifier les problèmes du financement de la santé communautaire en identifiant sur le plan de contexte, la première section que vous avez vue, la section sur le revenu et la section sur l'innovation, donc le financement innovant que vous avez vu également. Et par rapport aux conclusions de l'outil, nous avons pu identifier beaucoup d'éléments pour inclure dans le plan d'action 2025 du ministère de la Santé. Vous voyez, la cellule d'économie de la santé a pris en compte la dimension financement basé sur les résultats, Result-Based Financing in Work Plan 2025. Le dossier d'investissement, investment case, is taken in the 2025 work plan for Ministry of Health. Yeah. Aussi, l'élaboration du plan de financement durable, the development of a sustainability financing plan for community health system. Yeah, it's taken in the work plan of Ministry for 2025 because because of the tools. So, vraiment, c'est un outil fantastique qui dépend effectivement de la qualité des données aussi qu'on introduit. Donc, nous avons vraiment l'utilisé et nous croyons que des pays peuvent effectivement aussi l'utiliser. D'ailleurs, dans cette année, nous avons prévu donc de tester l'outil dans un autre pays comme elle a si bien dit. Voilà, c'est un peu ce que je voulais ajouter comme élément de complément sur ce qu'elle a dit. Actuellement, on ne peut pas parler d'impact. We cannot speak on impact, but effect by the tools, because we taken many things after the evaluation into the work plan of the ministry. 2025. Thank you.
You want to interpret? Okay, thank you. Maybe for me, I just wanted to respond to the lady that asked about the QI or quality, what are we doing about quality and all that. And for me, I think with this assessment tool, it is complementary to the other processes within government or within the Ministry of Health, because I want to believe that we have a whole, work around improving quality of care in Senegal. And so if with the views of the team of experts from Senegal and they feel like yes, RBF would work, then the model now will take shape in terms of identifying the indicators that are not doing well, and then now they model it around that so that there's that incentivizing quality within the Ministry of Health. Yeah.
Any other question?
Okay, thank you for that very insightful presentation. Mine is more of comments, not question per se. So I wanted to speak to some of the recommendations that were made during the course of the presentation, where you talked about making investment cases. I mean, that's a very good way to make a strong argument for investment in community health systems, where you can actually tell the government that if you're investing in community health system, this is the number of deaths you'll be averting, or this is the number of lives you'll be saving, or you can tell them that for every $1 you're investing, you're getting $10 in return. I mean, that's a very strong argument to increase funding or investment into community health systems. And then concerning the costing and planning tool, there's a tool called One Health tool designed by World Health Organization and the United Nations and some other organizations. So I think that's something, is a very comprehensive tool as well as very data intensive, and it's something I've been able to use for a few projects on immunization and mental health planning. So that's something you could also look at and see if it's something you can actually contextualize when you talk about Senegal. Yeah, that's it basically.
Oh, thank you so much for that comment. And yeah, that's a really good point. So investment cases are extremely important. And one of the things we've also discussed very recently is that when we talk to governments and we say, if you invest $1, you're going to get 10 back, there's also another way to look at it. So you say, if you don't invest in this, what is going to happen? And that is apparently really impactful, but it's also something that's difficult to do. And that's something we've been thinking about also working on is this cost of inaction analysis, where we think about what is going to happen if you don't invest in community health. What if there's a next pandemic? What if there's a next epidemic? What do you do if you're not investing now in community health workers? So that's something to also look at. But yeah, thank you for that comment. That's helpful.
Yes, thank you for the presentation. You mentioned that there was a lack of data to support the planning. And I was wondering, yes, besides what is in the tool, there is also data from other multiple sources. If you have like health information, you are able to look at maybe your catchment area, you know how many pregnant women you are going to have, how many children under 5, so that they can have those reflections and know what the actual gap. Then that goes to the next question. Does the tool allow the stakeholders to have some self-reflections on the priorities? Because now the questions have been, okay, you've done this assessment. If I have a little funding to support you, which area should be prioritized?
Yeah.
Oh,
Yes. No, thank you so much for those questions. So maybe I'll start with the second question first as well, and I'll also invite Madam Barke to come in. So I'll just make the initial comments. So on the second question itself, where you said, are governments able to self-reflect on priorities? So yes, so with this toolkit, we have the action plan, which they come together, sit together after they've made all the assessments. They would come together and say, now you have to decide what you're going to do about this. So these are the key issues we found. These are the recommendations that best practices suggest. But what is it that you can do in the next 5 years, 2 years? And how do you prioritize? So what is the first thing that you can do? And there's a priority level in that exercise where you say, first, we're going to address data gaps. Then second, we're going to look at X, Y, Z. So yes, action planning framework is designed for that, but we can definitely refine more and more to make it more sophisticated. And then the first question on the tools, ideally, when we started developing this, I think the ideal scenario would be having 100 tools integrated in one, and then the government would just go onto that platform and say, okay, this is the data we have, this is the impact this program has, this is the funding we're getting, these are the costs. So all of that in one place for that government or the people to see, and they can make their decisions based on that. So that's an ideal case scenario. But what becomes difficult is, for example, embedding different tools. So CHCPT, like was highlighted recently, so that's a costing and planning tool, which would assess the costs of community health programs and how they've evolved over time. But then how do you integrate that within this? Or you avoid duplication. So you don't want to duplicate what the CHCPT does. So you would want to come together, embed it. So that's where different stakeholders come together and they would integrate tools, or we can find ways to embed different activities in one tool. But an ideal case scenario would be government having all data, good data in one place.
Yeah, thank you so much for your presentation. I think the idea of toolkit is really innovative and insightful. I'm taking you back to the question that we asked earlier in the morning. And in this case, still about costing. So when you are talking about the investment case, if you invest in community health systems, for $1, this is what is returned. I want to flip it the other side and ask, are we able to then kind of cost how much community health workers are subsidizing the government? Okay? How much are community healthcare workers subsidizing the government? That is, in terms of the time and labor and what government would have paid, which they are actually doing and they're not paying. The reason I'm saying this is that whenever you're doing costing, if you're looking, say, from a societal perspective, you want to look from both ends, isn't it? From the government decision maker and say, if you implement this intervention, this is how much it's going to cost you, from a government or decision maker's perspective. But there's the other side of the user. So let's take the community promoters and workers and put them on the user perspective and say, how much is maybe productive days forgone doing community work? What does it translate, say, even if you're using a minimum wage, how much time are they putting in and how much are they losing, in which case they have actually paid for on behalf of government? And then have a conversation about moving towards fair compensation. That was the question we asked in the morning.
Yeah, no,
Okay.
Thank you for that comment. So that's really insightful, and actually looking at the community health workers' voices and just understanding data from that point of view is also really important. So that's a good research question, actually, that can be explored. So yeah, thanks. Yeah, Madam Baki.
Merci beaucoup et merci encore. C'est juste pour vous recommander l'outil parce que nous, on l'a pratiqué. C'est vrai que ça parle du financement de la santé, mais je vous dis, c'est un exercice qui est sérieux et qui se base sur des données probantes. C'est pas que on dit que oui, c'est élevé, c'est pas élevé, parce que lors de l'exercice, on sort tout document. Tout ce qui n'a pas de justification, on ne le met pas. Si on évalue aussi, c'est sérieux, il y a un atelier de validation et le document est validé. Ce n'est pas que c'est deux personnes qui s'enferment, qui écrivent ce qu'ils veulent. Non, mais c'est le diagnostic, je peux dire, sérieux du système de santé. Et ça aussi, ça nous permet, nous aussi, c'est un outil de plaidoyer. Parce que vous savez que le domaine du financement, si on parle de financement de l'État, ça va au-delà du ministère de la Santé. Par exemple, si je prends le ministère des Finances, plan, qui était là, c'est lors de l'évaluation qu'ils ont eu conscience de beaucoup de choses et eux-mêmes, ils ont porté le plaidoyer auprès du ministre pour l'augmentation ou bien l'inscription d'une ligne budgétaire pour la santé communautaire parce que ça n'existait pas au Sénégal. Aussi, c'est un outil qui permet d'avoir des actions rapides. On peut avoir à long terme aussi, mais nous, ça nous a permis de faire beaucoup de choses. Par exemple, après cet exercice, il y a un plan d'action quinquennal 5 ans, selon les priorités. Mais je vous dis, le plan de 2025, on l'a réalisé à hauteur de 80% et nous sommes au mois de mars. Donc, c'est des activités, peut-être qu'on n'avait pas eu pensé qu'on avait des lacunes sur ça. Mais c'est avec l'exercice qu'on a eu à le faire. Tout à l'heure, je vous ai parlé de la cartographie des ressources en santé communautaire. Ça n'existait pas. Lorsqu'on a fait l'évaluation, on sait que ça n'existait pas. Avec FAH, on est en train de le mener. Après, dossier d'investissement que tout le monde aura à faire aussi, on va le réaliser. C'est des recommandations ici aussi de cet exercice. Il y a aussi l'achat stratégique, on peut le dire FBR, basé sur les performances, qui n'a jamais atteint le niveau communautaire au Sénégal. Maintenant, c'est inclus dedans. On est dans le processus et incessamment, on va commencer. Juste pour dire que c'est très intéressant. Ça parle de financement, mais c'est global. Ça permet de faire l'autodiagnostic même du pays et de prendre les décisions qu'il faut. Donc, je tenais à faire ce témoignage et je vous recommande, vous tous, de le pratiquer et de l'adapter à votre pays. Merci beaucoup.
Thank you, Mbake. She was just trying to say that the tool is a very important tool that should be tested and implemented elsewhere in other countries. So based on the experience of Senegal implementing the tool has shown so many loopholes from different perspectives, and from that they set like action points for the 5 next year to come. And what is very, very important, these are even the small action points that can really unlock so many potential for community health workers. And one of the example, for instance, she said that the action plan that was set for 2025, as of now, in March, they have already realized more than 80% of activity that was set. So also one thing that she mentioned that I want to emphasize is like the tool, the data and information you saw here. It is not a random, they are not random information, because there is a tough validation process that happens. It's not like one or two person sitting somewhere and feel it. So they feel it in workshops, then they validate, then sometimes there are technical validation, political validation for it to get here. So it gets some validations processes. And importantly, where there are no data, they just don't feel it. So she was like saying, try it, it has its own challenge, but the benefits of using the tool are more than the challenges. Thank you.
Thank you so much, Madam Baki. That's yeah, really grateful for your support as well, and thank you for the insights as always. So unless there's any other questions, and we would want to wake up everyone from this lazy lunch and get into the breakout groups. So may I ask if we're ready for like a yeah, so what we'll do is we'll take about a 10-minute break so everyone can get some nice caffeine. So we're energized for a good breakout session because we're going to be able to hear everyone's voices. And this is not going to be quiet, mind you. So we're going to make some changes in the room so that everyone can come down and discuss some key questions. And then we'd be able to hear your voices in this session. So 10 minutes break, and then we come back for the breakout session. Please get some good caffeine or decaf if you're okay with that. Okay, so thank you, and we'll see you in 10 minutes. This one should work. Oh, the battery's down, is it? At least one mic. Hi, okay. All right, so yeah. So please find a group to just join in no order. Whoever, Wendy, do you want to join a group? For the people, for the French, for the Francophone region, we have a separate group here. So in case anybody only wants a French discussion, we can have a separate group. Thank you. So if you'd like to join any. All right, so just as we're here, maybe what we can do is we have people in front of us. We just write down the names of the people in the group and where you're from and which organization. So just your country, name, your organization, and this can be asked to anyone. So I can pick up anyone from the group and ask what the name of the other person is. So you must know who the people in your group are, which country they're from. So these two basics you must be aware of. So in case you're writing it down, please write down on the back of your paper the names of the people in your group and the country they're from. All right? So maybe for the people who are just arriving, so this group on the right is Francophone, so a discussion in French. Parfait, do you want to join the Francophone group? Oh, that's Francophone. Anglophone. All right. Do you want to play light music in the back? Just light music. Soft, really soft, subtle music, not loud at all. All right, so we see. Yes. Yeah, it's an exercise. 2 sessions, just an exercise. Just discussing, putting things down, and sharing.
So
No. I'll give context. Don't worry. I'll give context to this. It's not a random. Oh, okay. Oh, it's always on. Yeah, so just to give some context. All right, so well, firstly, as everyone gets to know each other, write down their names, their countries. So again, reiterating, before we start the session, please write down each other's names. So you must know the people in your group. So please know their names and the country they're from, because I can ask anytime. Yes, on the back of the paper, just use the back of the paper to write the names of the people in the group and the country they're from. And yeah, there'll be an impromptu test in the middle. And this exercise, yes, please, if you'd like to join any of the groups, if you'd like to join the Francophone group, that's here. Maybe if we want to add another chair. Right? Right there, if you'd like to. All right. So as we get to know each other, but everybody else is just, oh, you've memorized. So, she is? Diana from? There you go, you're not well prepared. You need to be well prepared. -1, so we have scores. Remember, we have scores, so I will ask who the other person in the group is, what's their name and which country they're from. Whichever group gets highest or lowest will win or fail. So there'll be a nice surprise in the end for the people who know each other very well. All right, so as we do that, maybe I'll give some context to the exercise and what we're going to do today. So I'll give 5 minutes just to get to know each other after this, and then we can, just memorize. I would play a memory game, maybe have a test in the middle. There'll be some chocolates for the, no, I'm just kidding, nothing like that. So we'll start for 5 minutes just to have a discussion. But then after that, we go into this exercise, which is the first breakout session. So if you see one of the papers on your table, it says Session 1, Strategies for Domestic Resource Mobilization for Community Health. So that is the first paper. And there are 4 questions on that paper. The first question is, what are the common barriers to increasing domestic spending on community health? What are the common barriers to increasing domestic spending for community health? And you can think about budget priorities, economic constraints. And in this case, I'd love for you to think about your own country or the country you've supported in your work or researched, or the country that you're aware of. So anything which brings in your experience, so you can highlight that and put that here. I would suggest maybe have one writer in your group. So one note taker who can actually hear everyone and put down the thoughts. So write down the answers in the box. One note taker for the group, whoever wants to take that role. And then in the end, we would also have someone who will share insights. And it's not limited to one person, anybody can share insights, but if you'd like, you can always have somebody to do that. So that's the first question. We have, what are the common barriers to increasing domestic spending? How can governments adapt to decline in external assistance for health? Now, all of this we've heard a lot today, but this is more about self-reflection and thinking about what is it that we can really do, what have we known in our work, and what have we learned today. Maybe you can incorporate some of that. So thinking along those lines, and the other 2 questions as well. So what innovative approaches can governments use to mobilize more resources for community health? And finally, the fourth question is which ministries and stakeholders are crucial for effective resource mobilization and what role do they play? So these are the four big questions. First, barriers to increasing domestic spending. Second, adapting to declining external assistance. Third, innovative approaches to financing. And fourth, stakeholder coordination and ministries coming together for effective resource mobilization. So these are the four big questions we need to answer today. Think about your own context, your own experience, share those insights in the group and we can note them down. And then in the end, we'll have people sharing insights. But do keep in mind, I can also ask anybody else's name and country and where they're from in the middle. So yeah, just make sure you know the group that you're a part of and the people around you, where they're coming from, because we don't want to have random discussions with unknown people. So let's know each other and yeah, try and answer these questions. All right, so we go away for 15 minutes. Time is all yours. If there's any questions, I'm here. And we come back after 15. Yeah. So there's 15 minutes for the discussion, and then we can share insights after that. So I'll come back with my mic after 15 minutes. Maybe I can put a time clock on the screen. Is it possible to share screen with time? No, nobody's going to come here and present anything. This is just informal. You just speak out whatever you think. It's not a presentation. We're done with that. There's been enough. All right, how are we doing? Are we there yet? Okay. So we'll take 5 extra minutes for this, but let's keep in mind, we need, now when we're sharing insights, we need to share in 1 or 2 sentences per insight, right? So it's not a long paragraph. You just share 1 or 2 sentences. What's the crux that you've found? So if you have 3 points in 1 box, you just share those 3 concise, clear points. It doesn't have to be big examples. So let's make this more rapid fire now. So we have 5 more minutes, 3 questions it seems. Let's go. we're just going to discuss the first one now. All right, so let's begin sharing our thoughts for the first session. I see there's been intense discussions. We've been in like strong panel discussions within our group. Seems we've had a lot of comprehensive insights shared, lots of experts in the room clearly. So now maybe we can start asking, what has the group found? So maybe let's start with the first question, and I would really say strongly that please keep your answers concise, clear. What are the 3 big things, 4 big things, 4 big insights you've found for the first question? What is it that you can share with us to answer the first question? So let's start with the first question. And I'm going to come to the Francophone group last. I'm sorry. So, So let me start with the first group. Let's say Dennis's table. So yes, on Dennis's table then, what did you find? What came out of this intense discussion the team was having? And maybe let me ask again, could you please name the lady next to you and which country she's from? Dia? She's from Rwanda. Well, nice to meet you. All right, so Dennis, would you be the one sharing your thoughts? Okay, great. So let's hear from you. What are the common barriers to increasing domestic spending on community health? What are the few things you found?
Thank you very much. Actually, it was a very good, insightful discussion. So about the common barriers to increase domestic spending on community health, we discussed about the conflicting priorities between other sectors with health and within the health sector itself. We also discussed the challenge about the access to financial access, and we talked about the community health system not well structured and not well integrated within the health system. Then we talked about the misalignment between sometimes the Ministry of Health and the Ministry of Finance on allocating the required allocate the required budget. Also the poor PFM, but also we discussed lastly the lack of evidence-based in decision making when the allocation of resources is being done. Thank you.
Wonderful. No, these are really strong insights. It's clear this was an expert group. So the one big thing that's clear, and it was highlighted, was that there is conflicting priorities across ministries. Is there any other group which has found something similar where you've said conflicting priorities? So this is really unique insight, yeah? So we've had other groups who have also said conflicting priorities is a big issue and a common barrier to increasing domestic spending. What other insights have we found? So let me go back there. It seems like it was really loud, this group. And Dorothy, let me ask you. So can you name the lady next to you and which country she's from? Oh, wonderful. There you go. Dorothy's top of her class. Wonderful. Okay. So who's going to share more insights and share thoughts on this? Miss Nancy. Oh, wonderful. You guys know each other well. Okay. Nancy, there you go.
So in addition to the ones that they've talked about, some additional ones that we had are historical domination of curative views of health, so that there is more prioritization of clinical services, building hospitals, that is linked to predominant investment in visible infrastructure, so health facilities and so on, and then also an entrenched belief in the volunteerism nature of the community health workforce. So yeah, I think those are the rest have been mentioned, right? Yeah.
Thank you. Is there any other person who wants to speak in the group? No? Okay. We've shared great thoughts there and really innovative as well. So we've gotten more insights from the group and we're all capturing them. So I'm going to literally snatch these papers and take it with me. Now we're here, so I see you and I'll ask a question. Gaia. So, okay. Yes. What is the name of the chair? And which country is the chair from? Wonderful. Okay. And what's the name of the beautiful lady? She's from Netherlands. We get it. We get it, Saib. Where is she? What's the name of the lady from Netherlands? Gaia, you've been sitting here. You've asked for extra time. Okay, we'll see what to do with this later. All right, so would you like, now you're going to ask the chair to answer questions. Oh, Gaia, terrible. Okay, I'll give you the mic then. Would you also give us your name, please?
I'm from the Netherlands and my name is Carmen from Cordate. So we talked a lot about we took most of our time on the first one. What are the common barriers to increasing domestic spending on community health? And we divided them up into three separate categories: political factors, economic factors, and social factors. When it comes to the political factors, we discussed that there's a lack of awareness of community health and their roles and importance at the political level. When it comes to economic factors, we had some of overlapping points as other groups. So the first, we had the government reliance on external funding specifically for community health. That was also a bit of a political factor. The second, large cost of running a community health worker program. The example in Rwanda, where there's 60,000 community health workers. So incentivizing them, training them, there's a lot of funding that has to go into that. And then also, similar to other group, competing priorities in different, within health, but also outside of health. And then social factors, we talked a bit about demand creation, so the mindset of patients and their responsiveness to specific services for community health workers. So, for example, family planning, but also sometimes a preference to seek medicine at traditional workers. And then also we mentioned a social factor could potentially be the hesitance of people to want to pay for premiums for health insurance, whether they view it as perhaps that they don't receive the quality that they would expect, or because of the preference to go to traditional health workers. So we also pointed that one out. And then for the second question, how can governments adapt to declining external assistance for health? We went through this one really quickly. So first, starting with understanding the funding gap, getting the right data in order to make evidence-based decisions, and also having a long-term sustainability plan. Then the third question, what innovative approaches? Oh, where we only go?
Yeah, just the first question, but great. No, wonderful. I think the first question was really, how it's structured was really well. So it's different factors that actually contribute to being the barriers for domestic financing for community health. And you've structured it as political, economic, and social factors, and including things like trust in public health services and in the kind of public health services. And there as well, we saw how historical nature of things has influenced how we see the service delivery today. So it's really interesting to see all of that as well. So we have a hand raised, and we're just going to come here to get insights on the first question, and I will hand you the mic, sir.
First question, I don't like to one comment. The question is increase the domestic spending. For me, you have some different domestic spending resources. Sometimes you have some resources, but you don't have the capacity to spend. You don't have capacity to absorb these resources. I don't know the answer. I think that it is so different. It is to resource mobilize, but our capacity to spend is so different. It is my comment. Thanks.
No, thank you. That's a very important comment. And yeah, that absolutely is, yeah, that's an important difference. That's true. All right, so we haven't gotten the final answers from this group. So I'll look at you, Pascal, but we also ask you, I'll look at you, Pascal, to give us the name of the lady in your group on your right and which country she's from. There you go.
You can see that I'm smiling. Then I know. I won't say she's the lady. No. She is Fatma. No, I know. I know. Fatma C. And the difference between the other Fatma, there is I in their name, Fatima, but for her it's Fatma. Yes.
It's okay. All right. So maybe if you'd like to share if there's anything else apart from the three groups you found in your group discussion for the first question, and if you'd like to share that. Yeah.
So quickly, to add on everything that has been said, we highlighted the fact that the community health is not institutionalized, and that serves as a barrier because it hinders its recognition at different level, and also the aspect of the voluntarism also act as a barrier, because when we want to advocate about something and to put it in any budget line, it needs when some people argue that these are volunteers and the entire discussion take another angle. So these two aspects has been identified in our group. Thank you.
Wonderful. Thank you so much. So we've covered the first round, and now it's not that we're going to go to every question. Maybe what we can do is there somebody who would like to talk about one specific question amongst the four and share insights on them? If not, my suggestion is we move on to the next session and we come back to these questions again in a rapid fire form. So we'll have 10 minutes for the next session. We have 3 questions on your table. Next session, 10 minutes. It's a rapid fire, so mind you, just put one sentence, go on, and everybody should have a voice. So everybody on the table should speak and write what they think. And I say that because at the end, I can come to anybody and ask what they've written or what was their contribution on the paper. So for the second round, it's a rapid fire and rapid fire questioning. We'll start with a 10-minute rapid fire for the next session. And maybe just to help out, I will read out the questions. If you want, you could also prioritize one big question you'd like to answer. So you don't have to answer all the three. Prioritize one or two big questions that you'd like to answer and which you think are most important in the state we're today. So the first question here is, what are the primary drivers behind donor transitions in global health? So why are donor transitions really happening? What is driving donor transitions? How does it affect community health? Which regions are most vulnerable to donor transitions, and what risks do they face? So which of the regions, maybe you belong to one, which regions are most vulnerable to donor transitions? And are there countries that have successfully navigated donor transitions? So are there successful cases which have transitioned, successfully navigated donor transitions, and what lessons can be learned from them? All right, so we see that there's a lot of, now people are getting bored there. I see that this classroom's getting a little messy. What's happening, Dorothy? What's happening? The classroom's getting bored, I'm saying. Yeah, okay, anyway, so the 10-minute timer starts now. And just pick one big question, 10 minutes, rapid fire, and we'll come to anybody to ask what they think in one sentence. 10 minutes. All right, so the rapid fire exercise is now finished. All right, so if everybody is ready, now I'm going to come to each table and I'm going to ask you which is the one big question you answered in your chart for the session 2. What is it that you found? What are the key insights from that question you found? And this is super rapid fire, and this time we don't have representatives from the group, so I'm just going to give the mic to anybody if you don't mind. So maybe I'll come here first, and I will give you the mic. Would you like to please share your name and which country or organization you're from, and share the insights?
Only one question, right?
Yes, whichever question you think is a big priority.
Sure. Thank you very much. I am Kaleb Melaku. I come from Ethiopia, and I work in Coordate Ethiopia. So let me start just by the first question, perhaps. So the question asks, what are the primary drivers behind donor transition in global health, and how does it affect community? One thing we raised is geopolitical change in many donor countries. For instance, in the US now, there are political changes that have brought the decline in funding due to the coming of President Trump, we mentioned specifically. The other is the need to save government spendings in the donor countries. So that's also another thing. Shift to defense budgets in donor countries. And certain donors, for instance, in our country, in Ethiopia, there was a war that was raised in 2021 that broke out. And during that time, certain donors retreat from providing funds for the country since it was in conflict. So these are the things that we raised. Thank you very much.
Amazing. Thank you so much for sharing that. I do see Trump has come a lot in discussions today, and not in a good way, I must say. So coming to the second group then, very quickly, what is the big question you prioritized, and what would you like to share? So I will give the mic to... All right.
Yes, thank you so much. In our group, we chose the question 3. Are there any country that has have successfully navigated donor transition? And we choose Rwanda. And we say that why we choose Rwanda, because Rwanda has already a good system that they established, having SWAP. I think this morning we discussed about SWAP, sector-wide approach, in charge of mapping all partners that are working in the health sector and the priority to see which sector, which program that they're going to intervene. And we say also Rwanda has the human resource tracking tool to track all data financial data, what they're investing on, and to make sure that what they are doing is really provide a good outcome. And there is also what we call a joint sector review, which is a biannual meeting where all stakeholders working in the health sector, they're discussing about different indicators and outcome to see how, and there is also a good opportunity to advocate from some diseases based on the available resources. And also, we say that in Rwanda, they have different meeting and let's say committees with development partners who are supporting the sector. We have like a technical working group. We have the DHMT, District Health Management Team. In quarterly basis, they are discussing about different indicators. and how to support the sector, the health sector especially. And we have also what we call joint there is, for the work plan to implement, especially for development partners, those who are supporting the sector, they have to be in line on the Minister of Health action plan to make sure that what they're implementing, they will contribute to the outcome that's the priority of the Minister of Health. This is very important. No partner can develop their own action plan without involving of the Minister of Health or the specific department to make sure that what they are doing, they are aligned with what the government needs as a priority. Yeah, in brief, this is what we discussed here. Thank you so much.
Thank you. No, these are great insights, especially, partner collaboration, partner mapping is so important, especially in the face of donor transition. And Rwanda has been a great example, and we've heard a lot about it today as well. So now I'm going to come to the Francophone region. In the Francophone region, what did we try and answer? I see, are there any additional insights that you found in addition to what the other groups have said for the second session, and you'd like to share that with us?
We are converging, saying the same almost, but just for the sake of highlighting what we, in our group, we mentioned, we, through the example of different countries that are represented here, we emphasize on the fact that it's important to continue encouraging country to raise funds internally via taxes. And there is several examples that has been given from different countries, Senegal, Ivory Coast, about teleco, where you can raise some funding through the tax, luxury product or product with a certain health impact, tobacco, alcohol, and so forth. And also we emphasized on the fact that creating more money through the community by, we gave the example of Rwanda, through the social health insurance, the mutuelle de santé, where people give money. And we emphasize the fact that though it's a small amount of money, but when you put it at a scale of the nation, it's become a good source of funding. So we encourage also other countries to think about that. And also to reduce fragmentation in the health ecosystem so that we bring more efficiency. And we gave example of different projects that was almost working towards same goals. You can have program for vaccination, for immunization, program for XY condition, etc. So by reducing that fragmentation and putting it within one single entity, we raise efficiency that can be, and the money, the money created can be used in other area of the health. Thank you so much.
Thank you so much for highlighting those points. And some of the things, I think one good thing that has come out of this one is that we can learn from different countries, not just from the country as a whole. No country is going to be perfect, but we'd have initiatives, small aspects that might be working really well for specific reasons, and we can learn from them. So as we wrap up, I'm just going to have a final say from the last group here, and then we hand it over to Dr. Parfait for the closing remarks. So the last group I see, may I just hand it to someone randomly? I'll give the mic to you to introduce yourself if you don't mind. So if you'd kindly share your name, please, and the country you're from, the organization, and what are the additional insights you found, or if you answered any other questions, and what would you like to share with us? What's the key takeaway?
Thank you, everyone. Okay, so my name is Blessing Raji. I'm a health coach working with MDoc Healthcare, a digital health company that helps people to live healthier and happier. So we decided to take the second question, question 2, and we highlighted the regions that are vulnerable to donor transitions. And responses are the Sub-Saharan Africa, this South Asia, and the Latin America. So we then delve into the risks that are associated with that, and we analyze that there's going to be a decrease in the health workforce available to deliver these services, because we are looking at the larger number, right? So there's going to be a decrease in the health workforce. Then secondly, we also highlighted that there's going to be a disruptions in the commodities, maybe looking at the areas where these commodities are to get to. If there is no proper planning for these commodities, they might get to halfway. So also increase in potential for brain drain. It involves what's it called, planning, right? It involves planning, and because we are also targeting the higher number, right? So there's a possible for you to have that kind of brain drainage, stress, mental stress, which might also affect affect continuity, because the pressure, you're not able to manage the pressure coming from this demand. So because of the mental stress, you have to dump the project. Then increase in workload for staff in public sector. So we also analyze that for the public sector, the workload will be much. So there's going to be an increase in the workload. So we then forge further to say, what are the strategies that can be put in place? Then we mentioned that it involves transition and sustainability plan for maintaining the donors. Thank you very much.
Thank you so much. That's super insightful. And yeah, having transition planning and some of the other things you've highlighted, they resonate with, I think, most of us today. And we've heard this time and time again throughout the day. So now wrapping up this conversation, I would advise if you could just flip the paper and write your names if you have not written already, because I would love to know who was part of the group and what amazing insights you've shared today. And I'm going to unfortunately steal these papers and take home with myself. So as we wrap up this session, and I'll collect all of these papers, I will please invite Dr. Bafe for the closing remarks for the day.
So your computer is connected? Yeah. Yes. My phone. Sorry. Hello. Good afternoon, everyone. I know we are all tired, so there's no formal presentation. I'll just go through the slides, just to read slides. I know you guys are very tired. So I just wanted to wrap up and share the summary notes of our discussion. So as we started, this topic around strengthening community health system for universal coverage in low resource setting. I'd like first of all to thank each and everyone. So we started the conversation with Dennis around the finance. How can we finance the community health system in South Africa? The takeaway message here is the government is the first purchaser of the health services. So it means that if you want to sustain the gain we have made in health,
we need more domestic, considering the current aid decline context. So and also another highlight from this conversation from Dennis, in this turbulent time, it's not critics that work, but working together, and we need more partnership than before. So there was an example from the current aid decline with the current president of the US. So we need, it's not about critics now. What works well, it's about how can we work together to add more value to our people. So the second presentation with Kandie, the health financing landscape in Kenya. So the key message here was how can we institutionalize resource mapping to guide the planning, prioritization, and also the resource allocation. And then include beneficiary in the identification of the needs and prioritization as well. Another element was about developing the sustainable financing mechanism, but more specifically contextualize the implementation arrangement. Not every solution is meant to go for scale. What has worked in Rwanda does not work necessarily in Ethiopia or in Ghana or in Cote d'Ivoire. What has been scaled up in Cote d'Ivoire does not necessarily being going to scale up in Kenya. So we need, not every solution should go, is meant to go for scale. Sometimes people are pushed for scales and yet it's not contextualized. So implementation arrangement, you need to assess the implementation arrangement. Investing in technology is also very important to ensure that service delivery is more seamless and efficient. So there was a very good panel discussion of we had five panelists here. So I just want to summarize some of the key takeaway message. That digitalization has been highlighted as a game changer in the service delivery. Distribution of community health workers will be based on disease burden or epidemiologic profile, evidence, and not political decision or political choices. And to ensure that everyone is quite covered. Need to institutionalize, there's a need to institutionalize performance assessment for the program to fit for the purpose. So it means determine, first of all, the service package we want to serve the people. And from the service package, we can then determine what are the type of cadre we need, the workforce that we want, the requirement in terms of competence that is required for those people, numbers, but also the capacity we want, but also design appropriate remuneration based on the current context, workload, and so on and so forth, and plus the supplies and equipment. So it needs also to empower community workers with the appropriate tool and capacity. Madam Beatrice has really emphasized it on the panel. So sometimes community workers should not be, they feel like going just following. They should be in the front line, so they be more empowered, so having voice up their issues, needs, so how they can take their needs can be taken care of. So adapt remuneration based on their existing workload, and designing and sustainable financing for community health workers with adequate advocacy tool, investment case to mobilize the political will. So it's not about rhetoric that's going to convince politicians. We need to convince politicians with evidence. Then they will make some decision, and they will need mix of funding. So no one can do it alone. So we need to diversify the financing. So we had some very good panel insights. So if we fail to live our vision, we live at the comfort of the system. That's what our sister Dorothy mentioned. And Madam Beatrice also, we meet everyday policies that we create and support. So we create policy every day and we support and at the same time we're the one complaining against those policies, and yet we are the one who we create those policies. So we need to be cautious what we are doing. So we need also to build capacity. There's an issue of capacity that was raised by AMI. Build capacity for the next generation of health financing people, but also community. So we'll have the last presentation with Shivani, the community health financing assessment, case of Senegal. So she also highlighted the same insights. So, but in addition to that, she mentioned that we need more money, a quantum of money for community health workers, but also a flexible way of spending it. There's no need of having a lot of money, and yet there's no budget restriction in terms of spending. So that's where the highlight from the findings. Another element was about the cost of not investing in community health workers. That could be also be explored rather than the other way around. We used to do the ROEs, but we need also to show the cost of not investing in community health workers. So let's continue to build evidence. It's not only one tool. We can have multiple tools as far as they are generating evidence. It's not just numbers. It's about policy action. So we need more action. So let's continue to advocate, even if you are, we think that we are small, but we can continue to advocate. By advocate, we collaborate, as we do here. We are doing advocacy, but if you do advocacy alone, it's not proper, but also quite not more convincing. We need to collaborate as a partner here, but at the same time, let's integrate when we go to engage the government. Let's integrate so we don't get creating the duplication and misalignment. And then by integrating, the end goal should be let's institutionalize so that by the time the lesson learned we learn from US withdraw, USAID withdraw, at least we have put in place a system that could continue for a long time. So thank you very much. Those are the key highlights. I think the rest, or the other insights came from the discussion that we had from the groups. Thank you very much for your kind attention.
Conversations. Oops, I'm sorry. Yes. Someone told me not to do that. Oops. So thank you once again. On behalf of Financing Alliance for Health, we are truly grateful for your time and your insights and the conversations that you had. If you'd like to talk to any of us, maybe show of hands, AfHEA team who are here, please. Feel free to reach out to any of us for any side conversations. And so, yeah, you guys can now break and go mingle and interact. But before we go, for our Muslim brothers and sisters, you can go break your fast at the Radisson Blu Hotel at 6 p.m. Just have your vouchers with you and you'll be directed which room. Other than that, thank you and have a good evening.